Moderator is Dr. Swapni. Yes, just
Dear faculty members, we'll be starting Hall C proceedings in 10 minutes. Dear faculty members, we'll be starting Hall C proceedings in 10 minutes.
Hello. Shobhit, can you just help us know if we are audible?
Yeah, sir.
Okay.
Good morning, everyone. Welcome to the Hall C of
Doctors, we'll be going live in 30 seconds.
Okay.
Atish, are we live?
सर हमने लाइव तो कर दिया बट फ्रंट एंड अभी यूट्यूब पे लाइव नहीं हुआ है.
So we'll be starting in 5 minutes.
Yeah.
Are you ready? Doctors, I'll be giving the countdown. So we'll be going live in 5 minutes.
Okay.
I don't have any slides. I will just put on one project. It is the narration. Okay. Just a talk. Colonel Sethi, Dr. P.K. Sethi.
Good morning, sir.
Morning. How are you?
I'm fine, sir. How are you?
I'm fine too.
Looking smart with the cap.
Yeah, I chose my own cap of my Army Medical Corps.
Yeah, I can see that. Your talk is going to be very interesting, I suppose.
Yeah, it is just to remember that we had a surgical strike long ago in 65 also, which went unreported because there was no TV.
Oh, I see. So you are reporting it now.
Yeah, I'm going to remind people that don't forget soldiers who are serving at high altitude in this weather. The neurology is fine, but the general life should be also listened to.
Yes.
Or how are you?
I'm fine, sir. I had that Delta COVID, but
Oh, you had a Delta COVID? My
yes.
That was before Omicron.
No, this month, last month only.
That was Delta.
Yeah, it turned out to be Delta.
That has to be, was it very severe?
It wasn't very severe, but something is troubling.
No. But were you hospitalized?
I just received remdesivir.
Oh, you did?
Yes.
Did
We
you
didn't know initially. Sequencing was done later on. But it was good that our pulmonologist decided to give me remdesivir.
Dear faculty members, we will be starting the session in 3 minutes.
Okay.
Dr. Puri is not logged in. He's the co-chair.
Has Dr. Vinod Puri sir logged in here?
I don't see. I don't see.
Rajesh, can you please confirm?
वो बोल रही थी कि डॉक्टर चंद्रा गया और सारे चंद्रा जो है
Adish, can you please confirm? Dear faculty members, we'll be going live in 1 minute.
Puri has not come? Not seen.
Should move it.
Adish, please tell us when we are live.
Sir, just confirm, then I tell you.
Okay, Adish.
So should we start? Sure, I think it's 11:30.
Doctor, we need to confirmation from the session manager. Adish?
Sir, give me 1 minute. Pradeep is calling him, then confirm.
Now we are cutting Pura, the and direct process to smoothly interact.
Adish, can we go live?
Yeah, sir.
Okay. So good morning, everyone. Welcome to the Hall C of conference. It's been a wonderful session till now in Hall A. So we are going to start with Hall C, and we are going to have three sessions in this. The first session, I would like to invite the chairpersons, Dr. Kiran Bala ma'am and Dr. Vinod Puri sir. Atish, can I have the slides for the faculty?
Adish?
So Dr. Kiran Bala ma'am is Senior Professor Neurology at PGIMS Rohtak, and Dr. Vinod Puri sir is former Director Professor Neurology at GB Pant Hospital, New Delhi. So we are going to have two presentations in this session, each for 12 minutes with a discussion of 3 minutes. I now hand over to chairpersons to kindly introduce these speakers. Kiran ma'am.
Good morning, everybody. I don't see Dr. Puri around. Has he joined?
I don't think so, ma'am. Can you please proceed with the introduction of speakers here? Yes.
Okay. Can I see the first, slide for the speakers?
Atish, please put on the slides for speakers.
It's my proud privilege to be sharing this session with my teacher and my mentor, Colonel P.K. Sethi, who's been instrumental in making me the neurologist. I was his student in Gangaram Hospital. He's really a neurologist and a physician par excellence. I've seen him working for the last so many years. He's emeritus consultant and ex-chairperson, Department of Neurology, Sir Gangaram Hospital, and President Brain Care Foundation. His special interests are in epilepsy, stroke, headache, spondylosis, movement disorder, nerve muscles, and he has over 187 national and international publications and released including 4 books. And he's been honored with many awards: Vishisht Seva Medal, General Amirchand Award for Best Paper, and President's Physician. He's been as a neurologist consultant, and Padam Shri in 2002 by President of India. Over to Colonel Sethi, please. He's going to share with us a very unique experience today. Let's enjoy that.
Thank you very much, Dr. Kiran Bala, for a nice introduction, and the other people who are listening to me. Today, I'll take you across to 1965. That is the first surgical strike which we did in Uri Punchnikap, and I was the regimental medical officer of that war. So this is a description of 1965 Uri Punchnikap, of the surgical strike across the border, and to which was witnessed by me as regimental medical officer. It was a chance remark by my wife, do Colonel also lead the troops and they die in action, which brought me back memories of 1965 war. I was only 25, 4 years old and fresh from AIMS, and I was the regimental medical officer Kandubra. We had to capture 2 formidable pickets in that war, 1965 war, which was called by us Raja and Rani. And by that, Uri Punchnikap would have been, we were starting from the Punch, and the Uri Punchnikap would have been completed, and we would have got the Haji Pir Pass. Those days, there was no TVs, there was no Barkhadat, this war was never kind of got the exposure and reported as by Kargil, but it was no less than the Kargil war. I will tell you it through my eyes. I was young medical officer, fresh from AIMS, working as a regimental medical officer to this great battalion of 3rd Dogra. The regiment was considered to be a crack battalion. In that sector, known for its valor, we were based in Poonch in Kashmir. We were caught unaware in 1965 when the infiltrators came from Pakistan and started capturing our places. We suddenly woke up when a message came from the head of the infiltrators that they will have their breakfast with our commander, Brigadier Zora Singh of 93 Brigade in 2 days from that way onwards. Time to act had come. 3rd Dogra, which was placed, my battalion, which is already in Poonch, the 2nd Sikh was called from behind to join, because we were supposed to go on war and to capture 2 enemy pickets, the huge one, Raja and Rani. Unfortunately, we had the beginning, we thought that the Dogras will first attack Raja, the 2nd Sikh will run through Raja and capture the next picket, which was Rani. They were adding more than 7,000 up. We had underestimated the enemy firepower and manpower. When Dogras attacked Raja the first day, with so much firepower came that they had to retract, they had to come back, and the word went around that Dogra have lost their nerve. My commanding officer, Lieutenant Colonel R.B. Nair, was so upset that he will not come out of his bunker and did not eat his food for 2 days. Major J.C. Verma and Captain Bawa, who were the commanders of the 2 leading companies from the Dogras, they were really in tears. They felt, how will they go back to the troops or face their folks at home with the shame that they had to retreat from the attack. As a regimental medical officer, I must tell you that regimental medical officer, although may be very young, has a unique position by being a link between commanding officer and the troops. Major Verma and Captain Baba asked me that commanding officer, I should approach commanding officer and tell that if the second attack occurs, they will be the one who should be chosen to go back and attack that picket. I conveyed that to commanding officer. Commanding officer in turn spoke to the brigade commander, and they were happy to give them second chance. The word went around that we are going to have a second chance and the Dogras may be able to prove their valor again. The plan was first to march up in the morning to our picket that was called 70, it is at 7,000 feet. And those 2 pickets were quietly seen from our picket, which was at 7,000. The fateful day arrived. There was early morning havan As Havan finished, offering to Durga Mata was given. Suddenly, Subedar Major of our unit, that is 3rd Dogra unit, became very emotional, and he lowered Dogra flag and took a shapath. All of them committed that they will not come back unless they get a Dogra, unless they get the Rani picket, and the Dogra flag will not be raised. I was sitting next to Colonel Khanna, who was leading the 2nd Sikh. He suddenly turned around. He was also attending that Havan. He suddenly turned around to me when the Havan was finished and wished me good luck. And I also wished him good luck in return. That was unfortunately the last time I saw him alive. Signalman of the unit started laying the lines picket to picket 70 so that we communicate from our base to our picket. I was told that there will be very few casualties, which I should take a haversack and few bandages and go up. It was a chance of altercation with my adjutant, Captain Jitinder Singh, that proved to be a great blessing. I insisted on moving my whole RAP. RAP is a regimental aid post, where the doctors over years had collected many bags of bandages and putties and lot of morphine and other equipment. I insisted that my medical platoon should be also given to me. Medical platoon, those who are not aware, is a platoon of about 10 people who are allotted to the doctor so that in peacetime they play band, but in war they are my real hands. I trained them a lot in the first aid and giving them bandage. CO stepped in and gave to settle the decision in my favor. I got the medical platoon and necessary khachars to carry the medical stores up. Early morning, as we marched to 7,000 feet with the haversack on our back, I found everybody in great enthusiasm. There was no fear, there was no scare, with cheerful face and determination to complete the mission. Havaldar Sukhu, the battalion wrestler, came near me as I was climbing up, and he said, "Sir, the Dogra tradition is the doctor never carries pittu." He took away the pittu from me, and he was marching up with 2 pittus up. I was really touched. We went up. It was a really steep climb. Tired, we reached our own picket 770 at 3 p.m. in the afternoon. Picket commander served us tea and pakoras. Major Verma and Captain Baba on that 70 picket, they recce the area to see from where both the pickets, Raja and Rani of the Pakistan army were easily seen. 5 o'clock in the evening, the officers gathered near the foothills of 70. We were hidden from the enemy because our picket was in between, and there were a lot of herbs and shrubs where we had this conference. The commanding officer passed the order, which are called OP orders, operation orders, and they were meticulously given to both commanding companies in charge, that is Major J.C. Verma and Captain Baba. I was also included in that group. I was told that as soon as they achieve the picket, a signal will be sent to me, and I will rush forward with my boys and medical equipment to treat the casualties. After OP orders were passed, suddenly Captain Baju, who was in the second leading company, turned me and asked jokingly, "Doctor Sahab, aapki taraf se bhi koi order, toade kol koi order?" I, being fresh from medical college, honestly was very scared from inside. However, atmosphere was so charged that I could not help saying, "Chak deo salan," blast them. As the dusk arrived, the Dogra started moving up towards Rani picket through thicklets. On the other hand, brave Sikhs of 2nd Sikh battalion started moving to Raja because there was simultaneous attack on both the pickets. First, the path was mined. The problem was so formidable as the path was mined and by the park regulars, and at both the pickets were much height. Even a bullet fired from up, the people who were attacking them will be sitting down. 6th Battalion was called the Royal Battalion with an honor to bear their line yard on the right side. Dogras had clear-cut missions. They have to bring their honor back, only then they will be able to raise their flags. The night fell. Each soldier was of 6 feet tall. The night fell. We were waited, hidden in small shrubs and trees, thinking our own thoughts. It seemed as if many hours passed. Suddenly, the firing started. Our artillery based in Punch base gave coverage to our troops. Many rounds were fired directly on Raja and Rani, and during this firing, quietly, the troops from 2nd, Sikh, and 3rd Dogra marched up to the respective lines. We were later to realize both pickets were very well fortified and double roof. As a result, when we reached there after the war, we found hardly any damage was done by so much firing from the artillery. Soon the atmosphere was rendered with war cries. Dogras were shouting Durga Mata ki Jai, and Sikhs were famous with shouting Bole Sonia. The war was on. Braving all the bullets, Dogra charged the picket and reached top of the picket. Hand-to-hand fight ensued. Pak really fought bravely. One Pak JCO hid in a bunker and won't come out. Lieutenant Shakti Kumar, who was not supposed to be, he was a quartermaster, he landed there and very bravely he went to chase this JCO out of the picket. Pakistan JCO lobbed a grenade at his face and his face was completely, jaw was hanging down. But this officer was able to overpower the JCO of Pakistan and killed him. On the other hand, Sikhs were having much tougher time. We got the pickets much earlier than Sikhs was having much more tougher time with Raja picket. The picket was much more steeper, possibly much better equipped by Pakistan. Hand-to-hand fight was very severe. Sikhs seeming to lose the hold and started running back. That was the turning moment. Seeing Sikhs running back, their commanding officer, Colonel Khanna, got enraged and shouted to his Jawans, "Look, Dogras have made history. Let us not be left behind." He took out his revolver and started marching up 2nd Raja picket. Colonel Khanna asked for reinforcements from the brigade, but nothing happened. A stray bullet hit him and he died on the spot. Seeing their CO dead, Sikhs were transformed.
Sorry to interrupt, sir. We are running a short.
Okay, that's 5 minutes. They shouted Bole Sonyal and hand-to-hand fight issue. The casualty started coming back only when Dogras got the picket fortified. Among the first population evacuated was Captain Bajwa. This officer had shattered with both thighs, but still he said, "Doctor Sahab, chak dete." Next was Shakti Singh. His jaw was hanging out. He tried to get up to salute me. I was really very scared that he may really choke. 200 casualties, both from 6th and 3rd Dogra, landed there, and we were very busy tying my platoon. He did a wonderful job of packing the thing and giving morphine shot. There was a very tense moment. One Sikh, 2nd Dogra, his brother was injured, his lung was hanging out, his head was shattered with the bullets, and he turned his stun gun to me, and he was at the moment going to shoot me. I explained to him my helplessness because I can't give him any medical care. Even morphine would have fell short of supply. I remember my last patient, X6 JSU, whose intestines were coming out. I put it back and helped the bleeding and used his own pant to tie it up. There was a total 200 casualties. Both our leading commanders, Major Verma and Captain Baba, lost their life, and so much many soldiers. Next day, Captain Jatinder Singh called me to his bunker. He was our adjutant, and I was sleepwalking. Nothing in my training ever had prepared me for this bloodbath. He told me, my adjutant told me, that our Major Verma has left an envelope and he wanted to open it in my presence. Across it was written to be open in the event of my death. Inside there was another envelope addressed to his fiancée. I still remember her name, Anjali, who was to marry him 2 months later. And there was a letter for us. It read as follows: when you go home, tell them of us, for there tomorrow we have given out today. That is the story of our picket going surgical strike across the border. It was never reported because that there was those policy was that we used to feel to be goody boys, and there was no TVs and there was no barkada. These people, soldiers, died there. The most shattering thing was we not only got across the enemy, we captured the picket, we stayed there for a month, and 1 month later we had to hand over pickets back to Pakistan, because in Tashkent it was decided by Lal Bahadur Shastri that we have to return the pickets. And that day we really cried that we, having won such a battle, we had to give the pickets back. So ours was first surgical strike in 65 across the Pakistan, and we stayed. I ended here for you to decide, and if you want to ask any questions.
Thank you, sir, for sharing such a sensitive issue. We are really proud of our soldiers and the army, which is looking after our safety and security, and we must salute them. And I think you should publish it somewhere so that more and more people of India know about this brave act they have done. In 65, I think I was a school-going student at that time. I remember vividly.
See, there has been a change in policy. We actually, next day, we had no way out. We had burned those dead bodies in the earth itself. Now
Yeah,
it's a great change that you bring them back and give them the honor. Now there's been change in policy, giving the honor to the soldier, and therefore I put on my cap after many years. Say that
they deserve that honor.
Yeah.
Thank you so
much. Most of you have seen me as a neurologist. You don't know me about my humble start as a medical officer. But I must tell you, it's great to be with them. Even now, I get their Part 1 orders, and I am always with them.
Thank you so much, sir. Anybody who wants to make any comment or ask him anything? Okay, thank you, sir. Then we move on to the next speaker, Dr. G.B. Burman. Can I have the speaker slide, please? Dr. G.P. Burman is a consultant neurologist in Hisar, in Haryana, very close to Rohtak, where I am working. And he has worked in PGI also for some time. And He's going to talk about immune-mediated epilepsies today. Over to Dr. Barman, please.
Yeah, I'm audible. Our screen is not being shared.
So the screen is on, sir. Your screen is visible.
Screen is not being shared.
We can see your screen, sir.
You can see the screen?
Yes, sir.
Yeah, screen is visible. You can share the slides. That's right.
Yeah, it's visible?
Yes.
Yeah, it's visible.
It's visible.
Look, it's a
Thank you,
slideshow.
Professor Kiran Balaji. Thanks a lot, Professor Puri and the DNA executives. So it's an interesting topic, immune-mediated epilepsies, also known as autoimmune epilepsies, previously known as autoimmune encephalitis. It's a really an interesting topic. Previously, there are just suspicion that these epilepsies may be having some immunopathogenesis, but subsequently ILA made it official that immune-mediated epilepsy is the fact because of presence of antibodies in blood, autoantibodies in blood, and CNS inflammation evidenced by CSF examination and neuroimaging. So it's a distinct entity. Approximately 30% of all patients of epilepsy, are DRE. But out of that, it's not idiopathic. It's most of them, more than 50% are immune mediated, and both the immunities, T cell and B cell mediated immunity, perhaps plays an important role. So I'm going to show a couple of cases, interesting patient who are proved to be immune mediated. This is an 18-year-old boy presented with jerky movements of right upper limb for more than 3 months. Started following a brief gastrointestinal illness. He was put on ATT by gastroenterologist based on the endoscopic finding and MAN2 positive, but this aggravated his symptoms and ATT was stopped. And he was put on multiple anti-epileptic drug, anti-seizure medications he was taking for more than 2 months. There was a history of one generalized tonic-clonic seizure also, and investigation was done in Jaipur. This MRI was done in 3 Tesla in Jaipur, and MRI was normal. So he was put on seeing that it may be a kind of movement disorder. So possibly hyperkinetic movement disorder. So triaxiphenidil and Rivocon was added along with anti-seizure medications by neurospecialist there. But there was no control of the abnormality. You just have a look at the case. In the right upper limb, it's a continuous coarse tremor-like movement. There is an posturing in the wrist. And if you see minutely, you can appreciate there is some twitchings in the facial muscles, predominantly on the right side, and involving the orbicularis oris also. And it was intermittent, sometimes continuous throughout the day, and gets little relief with anti-seizure medications. In between, he gets relief, but it was almost continuous. He was seen by psychiatrist also, and considering it may be psychogenic, he was put on antipsychotics as well. We investigated the case, routine hemogram, metabolic parameters, liver function, kidney functions, and workup for Wilson's. Those are negative. Viral study, triple antigen, also negative. We also sent anti-TPO antibody, NMDR antibody. Those are also negative. CSF as a routine, no abnormality. Cell count. Cell count was little high, about 6 cells, all lymphocytes. The EEG showed some abnormality, and classical delta slowing and delta brush was seen in the EEG during seizures. A repeat MRI we did with contrast that showed very minor changes in frontal lobe, non-enhancing, and radiologist passed it as non-specific. Significant EEG changes are there. You can appreciate that there is delta slowing bifrontal with delta brush as well. So considering refractory focal motor seizure as a manifestation of epilepsy partialis continua involving faciobrachial distribution with possibility of focal dystonia at wrist, along with anti-seizure medication, he was put on methylprednisolone with a dose of 1 gram in a day in drip infusion for 5 consecutive doses. And oxcarbazepine was added. He was already on levetiracetam, valproate, and johnsamide. Focal seizures decreased to some extent on day 4, and from day 4 he was put on IVIG also at a dose of 0.5 gram per kg in 2 divided doses. Only 2 days were given. Then because of cost factor, relatives was not willing to continue the dose of IVIG. Oral mycophyt, that is and immune modulator drug, methylphenidate, and that was also added. And there was some relief. IVIG parents no longer wanted to continue, and they took discharge on oral steroid, mycophenolate, oxcarbazepine, levetiracetam, and johnsamide polytherapy, with a plan that valproate to be withdrawn gradually because patient was already taking levetiracetam, 1 broad spectrum and 1 narrow spectrum of oxcarbazepine. So we are planning to withdraw valproate. The CSF sample, which was preserved earlier, it was not sent for anti-NMDA or antibody. It was sent, and report came to be positive. The boy lost follow-up, shifted to Delhi Sir Gangaram Hospital, and seizures were controlled temporarily. Again, he came back on steroid, mycophenolate, anti-seizure medications, again relapse of symptoms, and now presently he is under care of AIIMS New Delhi. They are planning, I don't know why they are planning for botulinum toxin therapy, probably considering it is dystonic tremor. So now coming to the another interesting case in a child, that 4-year-old child who brought in emergency with uncontrolled seizure. 2 loading dose of antiepileptics are already given by pediatrician. There is a history of fever which subsided, course of antibiotics and antibiotic over 3-4 days back. You see the abnormal seizure-like movements in the child. There is facial twitching and continuous eyelid twitching. You may pass it eyelid myoclonia, but there is no seizure in the body. And this was continued. This video was taken by the patients. It is not the video of the hospital. There is some twitching movement started in left upper limb also. This was continuous. Anti-epileptic drug, 2 antiepileptics are tried, epsolin and levetiracetam, of no use. The seizures are continued. So basic investigations was sent immediately. Emergency CT, CSF examination ruled out meningoencephalitic illness, biochemical parameters, oxygen saturation, liver functions, no significant abnormality, TSH, TLC was little high. And immediately dorazepam IV infusion was tried, followed by loading dose of valproate in 10% glucose. Partially controlled, so anesthetist called for short anesthesia. Propofol anesthesia was given during infusion. MRI was also done. Child was okay, and IV maintenance dose of valproate. Focal seizure recurs after 6 hours, so lacosamide was added. Methylprednisolone was continued 1 mg per kg body weight for 5 consecutive days. Gradually shifted to oral medication, semi-ketogenic diet. There is recovery, no recurrence. So see under anesthesia that MRI, there is some hyperintense signal in flare and pseudo-periodic complexes, spike wave discharges with bihemispherical slowing. Classical delta brush is not there, but bihemispherical slowing are there with pseudo-periodic complexes. So by definition, it is status epilepticus. As per new definition, more than 5 minutes tonic-clonic movement and focal seizure more than 10 minutes. These are status. So it is status and refractory to treatment. It's a medical emergency, persistent seizure in someone without a history of epilepsy. And there might be some cases, there is history of mild flu-like illness as this child had. So most common identified, and meningoencephalitis has been ruled out. So most common identified cause is NORS. It is an autoimmune encephalitis. It is an autoimmune induced seizure. So NORS and fires, these are very fascinating conditions. Febrile infection or illness related epilepsy syndrome, fires. It's a subtype of NORS preceded by an infection with starting between 2 weeks and 24 hours prior to the onset of refractory status. Fire is now considered as a type of NORS. Both conditions are postulated to be immune mediated and very fascinating conditions. So when to suspect AIE, autoimmune induced epilepsy, that acute onset or subacute onset, at least 2-3 months history, changing pattern, multiple seizures, faciobrachial dystonic pattern, and personal or family history of autoimmunity may or may not be there. History for the elderly, neoplasia, you have to take viral prodromes, prior onset of illness, evidence of CNS inflammation in CSF and in MRI. In first case, the MRI was normal. Status epilepticus may be the first presentation. So underlying CNS infection must you have to rule out. So in that case, first case, this MRI was normal in 2 occasions, and subsequently there's some non-specific changes. And NMDAR antibody mediated is the commonest form of immune mediated epilepsy. Anti-NMDAR antibody, other forms are there, all described in literature. So anti-NMDA receptor encephalitis is the commonest form. MRI is abnormal only in 1/3 cases, with cortical, subcortical hyperintensities, mostly normal, more than 70%. EEG is very diagnostic, diffuse slowing, delta VRAS, and this is published in ILAE already. And they respond well to immunomodulator therapy and anti-seizure medication combination. So take home message that high index of clinical suspicion is essential in every refractory seizure or drug-resistant epilepsy or in new onset statal epilepticus as first presentation without any past history of seizure. And autoimmune cause would be the diagnosis, even if there is no history of autoimmunity in family or in the patient. Presence of at least 1 neural antibody, inflammatory changes in spinal fluid or in MRI. Thanks for your kind attention.
Thank you, Dr. Burman, for sharing these interesting cases of autoimmune epilepsy. Any questions or comments from the delegates?
Professor Binod Puri is having huge experiences in refractory epilepsies and drug-resistant epilepsy.
Unfortunately, is not joined today. I don't
Okay,
see
Professor
him.
Puri has not come.
Yeah.
He is also my teacher.
Yeah, I don't see him. So you're right, the autoimmune epilepsies is a entity which has been recognized in last decade or so, and we are seeing more and more cases, and a high index of suspicion, of course, is required. And one needs to consider and investigate as far as possible, even at places where the antibody facility is not available or due to financial constraints, it cannot be done. If we have high index of suspicion, we must treat them with immunotherapy and give them the benefit. Thank you. Thank you so much.
Ma'am, only NMDAR receptor antibody is available in Lal laboratory and NMDAR.
No, others are also
Others
available.
are not available, not readily available. You have to send the samples to Bangalore.
No, in Delhi, they are available.
Achha.
With Metropolis people,
Okay.
they are doing. Most of the people are doing it now. Delhi, it's easily available. Hisar, it may not be. It's difficult for you to.
Lal, Thyrocare, they are doing.
Yeah,
this.
Metropolis people are also doing.
Metropolis.
Yes.
Thanks a lot.
Thank you.
Thanks a lot to the chairpersons, and thanks a lot, sir, for great lecture. I now hand over for the moderation of next session to Dr. Aditya Bhati sir. Sir, kindly take over.
Yeah, a very good noon to everyone, to the faculty members, chairpersons, and all the delegates. We are into Hall 3 and day 1, and it's my honor to invite and welcome Professor Arvind Chaturvedi, who is head of the department Neuroanesthesia, All India Institute of Medical Sciences, Dr. Praveen Gulati, head of the department Gulati Medical Center, Professor Vaishali Shuri, who is a neuropathologist, All India Institute of Medical Sciences. May I request chairpersons to please invite speakers.
Okay, good afternoon, sir. Dr. Vaishali, can you invite the first speaker?
Yes, sir. Good afternoon, everyone. It is a matter of honor and pride for me to invite my teacher and mentor, Professor R.K. Saran, who does not need any introduction. He's a very renowned neuropathologist with keen interest in neuro-oncology as well as muscle diseases. So today he'll be speaking on inflammatory myopathies. Sir, over to you.
At the outset, I thank the organizer and especially Dr. Ranjan and Vaishali for giving me an opportunity to speak about. Are you able to see my screen?
Yes, sir.
But I am not able to see my screen. I don't know why it is happening. Okay, and
now it's visible, sir.
Not visible, yeah. So thank you, Vaishali. Definitely a very important honor to me that the organizer has given me opportunity to speak something about the inflammatory myopathy, the histopathologist perspective. Basically, for over 40-50 years, many classification has existed from neurogenic muscle disease, neuromuscular transmission disorder, myasthenia, inflammatory myopathy. That is the today's topic, destructive myopathies, DMD, BMD, LGMDs, and some mitochondrial or maybe storage disorder, lipid, or the glycogen, or some congenital myopathy where there is no usual destruction are seen, but the minimal adhesion or protein excess can be seen in dysmenomyopathies or others. The histopathological classification by Carpenter and Carpeta in 2001 has divided into 8 categories. The 7th one is the inflammatory, and that is the today's topic. So recent concept about the idiopathic inflammatory myopathy that is has been divided into these 5 categories. That is the DM dermatomyositis and anti-synthetase syndrome, ASS, or immune-mediated necrotizing myositis, NAM, or necrotizing autoimmune myositis. And actually, this is the important entity that has come out over the time as a many robust entity. And then the sporadic inclusion body myositis, and other is the overlap myositis associated with rheumatoid or the connective tissue disorders. Please, we have to note that the polymyositis was the earlier one of the important category, and in the recent concept is a non-existent entity or a very rare entity. So which can be reflected by this article in the current opinion in neurology 2019. In 2012, Dr. Nishino has done one study in which more than 700 patients from all over the Japan. Clinically, 257 were suspected of myositis, and clinical diagnosis offered were 35% as a polymyositis, 18% as dermatomyositis, and 17% as a sporadic inclusion body myositis. When the biopsies were done to this, the main category emerged out in 2012 was immune-mediated necrotizing myositis in 21%, dermatomyositis in 13%, and sporadic IBM in 11%. Only 4% they could classify as the polymyositis. Non-specific myositis is around 10%, and sarcoid is 0.4%. This article, this Cell 2022 that appeared, morphological characteristic of idiopathic inflammatory myopathy in juvenile patient. Now, the subclassification of juvenile idiopathic inflammatory myopathy is necessary because there are many specific treatment that has occurred. other than the steroid and immunosuppression, the JAK inhibitors are also come into play. The newer things that has come into the discussion and robust finding, which was earlier not embedded in literature very confidently, was that the COX deficient fiber in dermatomyositis, and these COX deficient fibers were usually in the perifascicular location. Second is the perimycyl alkaline phosphatase positivity in the anti-Jo1 antisynthetase syndrome cases. And these cases were these subclassified as a type 1 interferonopathies. Now the DM, that is dermatomyositis, is now called as type 1 interferonopathies. This article, which is appeared in 1997 in the neurological clinics by the Amato, has classified the old way the literature was there, the dermatomyositis, the polymyositis, and inclusion body myositis. If you realize that in dermatomyositis, in polymyositis and in IBM, the CD8 positive cells invade non-necrotic fiber. So non-necrotic fiber infiltration by CD8 positive, and these fibers should express in excessive of MSC1, that is HLA1. Usually sarcolemma of the muscle does not express HLA1. But these non-necrotic fibers should express HLA1 and CD8 positive cells should destroy. And in contrast to that, dermatomyositis, perivascular, perimycial, endomycial infiltrate by the CD20 positive cells and helper T cells. They also have a myxoma virus associated resistant protein, MXA, or the membrane attack complex of the complement deposition into the around the muscle or into the vessels, both. But now this concept has gradually changed. So there is a dispute controversy over diagnosis of dermatomyositis and polymyositis. Among rheumatologists, they don't think there is a need of biopsies. And in the neurologists, biopsies is a must. What was the invasion of a non-necrotic fiber by endomycial inflammatory infiltrate all has atypical polymyositis. Several clinical characteristics of inclusion body myositis was actually seen. And that was the different concept that arose between the neurologists, neuropathologists, and that's why I'm here to come to present the viewpoint. That is the summary that has appeared in the BMJ 2004. And that is the very important thing. From histological perspective, this statement may not be valid because polymyositis patient in original source of this may actually have an inclusion body myositis and not polymyositis. This is the very important point that the BMJ in 2004 has said. The diagnostic criteria in which the presence of this histopathological feature is a prerequisite for diagnosing polymyositis are erroneous and are not based on solid original data. And this is why, because this invalidate features seems to have become embedded in the medical literature through a combination of authors' tendency to use review article as reference, authors not familiarizing themselves with the original publication, and authors who have a strong tendency to refer themselves. And these are the reason the polymyositis were overdiagnosed, and actually the disease is probably non-existent. The new markers have expressed ISC expression of HLA1 and in the non-necrotic fiber in idiopathic inflammatory myositis in absence of inflammation. That is but in contrast that we realize that any of these DMD, BMDs and dysphoronopathies or facioscapulohumeral also can express the MSC class 1. So this is also not a robust system of the interpretation. Second is newer ISC markers are proposed, and that is in dermatomyositis with the typical skin rash and no perivascular atrophy, sarcolemic myxovirus resistant protein A, that is the MXA expression, is taken as a bit more sensitive than the capillary membrane attack complex deposition. And this is claimed to be a slightly more sensitive marker for the dermatomyositis. Immunostainer for P62 is also taken, although not specific for IBM. That is to differentiate. So to devise histopathologically, we have this entity DM, NAM, sporadic, overlap, polymyositis, peri, eosinophilic myofasciitis, granulomatous myofasciitis of trachinella or sarcoid, or the non-specific myopathies. DM is essentially a complement-mediated microangiopathy. That is very important to see. And that leads to destruction of capillary. And because the capillary and vessels arise from the septa, so septas are on where there is a branching vessels goes. So all the filtrate of the antigen, antibodies and complements are first filtered out near the septa. That's why perifascicular, there is a destruction of capillaries, so hyperperfusion and inflammatory cell stress, perifascicular response. I have told you that a CD8 positive is embedded wrongly in literature, and that's why this is seen. So sporadic inclusion body myositis also have a cytotoxic CD8 positive cell directly invading the healthy muscles and MSC overexpression. In addition, some of them may show rimmed vacuoles in the myofibrils, granular bluish material or rim on the modified Gomuris trichrome, or World's myelin figure or beta amyloid, any stress molecules that you can see. Irregular ragged red fibers on MGT, I will show you, and the COX negative fiber that has come out more defective, but it is in the not just a perifascicular location as in DM, but also to the many things, and paracrystalline on the EM. So overlap syndrome associated, you realize that many of the rheumatoid other things may have some myopathies, and they have a mild inflammation and non-specific features. This entity, necrotizing autoimmune myositis, NAM, or immune-mediated necrotizing myositis, has come out as a major chunk, viral-induced, or maybe the ICU-induced myopathies and weakness, in which our autoimmunity with macrophage as a final effector cells, or immune-less. They said it is no inflammatory cells that you can see usually, and only on ISC you can realize that they are the CD8, 68 positive macrophages are there. Very few or no CD8, but can be seen. On eosinophilic myositis, granulocytes are the other entity. So typically for diagnosis, the pathologist needs clinical and the lab investigation, and there are some clinical things which I may omit. The fresh frozen tissue has to be done open on needle biopsies, and there are ways to do it with the frozen and the primary, secondary antibody and DAB and the staining to see under the microscope. Pathologists see the sarcolemmal, these as a positive brine stain, to call them positive stain, and if these sarcolemma is not taking any stain, and this is the positive, this is negative stain. And that's why we can see any antigen antibody. So we put antibodies, different antibodies, and they are precipitate over here. There we call sarcolemmal expression. And if it is in the parenchyma of it, then we say it is in the substance. So in dermatomyositis, like you see the muscle, there are these fascicles are there. And if these fascicles, you realize these are the epimysial perifascicular region, and this is the endomysial region. So perifascicular atrophy of the muscle, we can see in the dermatomyositis. In the sporadic inclusion body myositis, here CD8 positive cytotoxic cells directly invading into it and causing destruction with HLA overexpression. And same with the polymyositis. Now this is a redundant entity. And NAM is the necrotizing autoimmune myositis, have only CD68 positive macrophages. Rarely we have T cells and eosinophilic other things that we know. So this is the typical cartoon that I made it. Perivascular location in dermatomyositis, and inside the muscle directly invading the healthy muscle, these CD8 positive cytotoxic cells, then these are the causes of the SIBM, and may show some of the vacuoles and rimmed vacuoles in addition to that. So in addition to that, the pathologists also need this data, that is the DM or the DM associated specific antibodies, that is the myositis specific antibodies that are known, and typical type 1 interferonopathies that is now called as, only seen in 70% of the cases. They are the new armamentarium of the antibodies that are shown. The immunohistochemistry for the MXA has now available, myxovirus resistant protein A, which is a response of the body to a virus infection, and it prevents the virus to proliferate. So this is essentially a human body protein which express into sarcoplasmic expression in muscle fiber as a marker for surrogate marker for the dermatomyositis, especially in the perifascicular location. Now the embedded literature is increasing where the pattern of the MXA expression has also changed, and this is also one of the reason for and this interferon induced protein is actually a surrogate marker for the viral infection. Like a procalcitonin is CRP marker for the bacterial infection. Similarly, MXA is a surrogate marker for the viral infection. So immune-mediated necrotizing autoimmune myositis may have.
Sorry to interrupt you, sir.
Yeah,
we are running out of time.
Okay. So I am showing you is one of the things of the 65-year-old male where the necrotic fibers that you can identify. There are the splaying of the myofibrils and things you realize that these are there, and only scattered CD64 macrophages are there. So these are the biopsy were consistent with immune-mediated necrotizing myositis. In young female of 12, you realize these are the perifascicular region where the inflammation are there in the perifascicle, realizing that these are the inflammatory cell which causing destruction and perifascicular atrophy. And these atrophic fiber is a hallmark for the dermatomyositis. There are overexpression of HLA and also but rarely at times the CD8 positive, which is contradictory things that has called them juvenile dermatomyositis. The perifascicular atrophy is a important feature, but at times we realize that the inflammation is gone inside rather than the perivascular location like these. They may have a 20 positive, but T cells are also positive. And these you realize that they directly infiltrating to healthy muscles along with the perivascals is also a feature that you can realize. And there is a overexpression of HLA to these. So these are the cases where for pathologists, there is a problem to finally call them whether if there is a CD8 positive, CD4 positive cells are there, whether these are actually the cases of a polymyositis or dermatomyositis. But with the age and other things and inflammation site and HLA, they are showing that these are old cases of the dermatomyositis. MXA, that is the myxovirus expression, is also part of the thing. Patterns are now important things, and there are many things that I may have to skip it. But the pathologist armamentarium is very limited. HNE, histochemistry, COX, and many of the ISC, which gives you impression. And there are various presentation of dermatomyositis where CADM antibodies may be helpful. So SDM, sporadic IBM need not be a classical case of and no diagnostic marker exists. But there are many things that is as a stressor molecules that can be seen in all these things. So none of these are specific for the IBMs. So I may skip all those things to realize that many times these deposits can be seen in modified Gomori trichrome, and the inflammatory myopathy at times are mimickers with the muscular dystrophies of the Khalidkar article that we still can realize. On the conclusion, what I have to say is the inflammatory myopathies are the group of immune-mediated muscle disorder with possible degenerative component is in the IBM. And the histopathology is the most sensitive diagnostic tool, but interpretation needs full clinical and lab assistance. And that is actually my request to all my clinicians to give me, only then we can correlate. And histopathological evidence of the DM and SBM is clearly defined and reproducible. However, PM, that is polymyositis, remains a diagnosis exclusion and existent, actually non-existent. And ISC staining for MSC class 1, HLA1, MAC, that the membrane attack complex of complement, CD8, CD68, 4, 20, CD3, that is T cells, and the B cell markers are very helpful to classify. And sensitivity and specificity of these stain varies in different groups seen in literature. And because their clones are different, so they are not particularly defined, and absolute staining pattern of particular group is very, very important. So thank you. Thank you for patiently listening, sir. Any question if someone wanted to know? Hello.
Thank you, sir. It was a very elaborative as well as a lucid talk. And we can go on to the next speaker now.
Okay. Thank you. Thank you, sir.
Thank you, sir.
Thank you, sir. Thank you. Dr. Gulati is there?
Yeah.
Dr. Gulati, can you introduce the next speaker?
Yeah. I am really happy to invite my dear friend, Dr. Harsh Mahajan, to speak on neuroimaging in acute ischemic stroke. We all know Harsh very well, whether radiologist, neurologist, neurosurgeon, or any field of medicine. He's a Padma awardee, probably one of the youngest doctor to receive this award by the government of India. He's the founder of Mahajan Imaging. We all know that very well. You all may be knowing that he's also the founder for DNA. He was one of the founder member of DNA. and he's our past president of IRIA, a great friend, great radiologist, and great speaker. Harsh, please, your talk.
Thank you very much, Praveen. It's indeed a pleasure and an honor for me to be here. I'll just start sharing my screen. Can you see my screen, please?
Yeah, we can see. Yeah.
Thank you. Today, the topic given to me is neuroimaging in stroke, and we'll go straight into the topic proper. With the rise of endovascular therapy, we are seeing that there has been a marked focus on imaging for ischemic stroke. For more than 2 decades, intravenous TPA was the only approved therapy for acute ischemic stroke. Recent trials have demonstrated a high degree of efficacy for endovascular treatment in strokes by large vessel occlusions, and this heralds a new era. There have been multiple trials, the MR Clean trial, the ESCAPE trial, the extended IA trial, which have shown that this is highly efficacious and very, very useful. What is the role of imaging in acute stroke? Imaging is now basically used to determine the following: the location of thrombus, the volume of the infarct core, tissue viability, and degree of collateral circulation. We have 2 modalities available, the multi-detector, multimodal CT and multimodal MRI, both of them competing with each other. Multimodal CT really has been the mainstay, which includes a non-contrast CT, a CT perfusion, and a CT angiography, which is capable of addressing all acute imaging needs for screening and thrombectomy candidates. It rules out hemorrhage, identifies large vessel occlusion, detects infarct core and penumbra, and also is able to assess collateral flow, which is important. Also, as compared to MR, accessibility to CT is fast and more efficient. It takes lesser time, though as we'll see, even MR is becoming equally efficient. Now, to rule out hemorrhage, NCCT is standard for imaging intracerebral hemorrhage and can reliably identify acute hemorrhage with high sensitivity. Having said that, susceptibility weighted imaging is very highly sensitive to microbleeds. The chronic and the tiny microbleeds, and this is where MR scores. But does that really make a difference? Well, neither the presence nor the increased risk nor the number of cerebral microbleeds. So presence and number of cerebral microbleeds actually does not lead to any increased risk of hemorrhagic transformation. So even if we do not see these microbleeds on CT, it is thought that it doesn't really matter. Hemorrhage, we are all used to seeing various kinds of hemorrhage. Now, for detection of large vessel occlusion, CTA can be performed and is performed immediately following NCCT. It is fast, less prone to motion as compared to MRI, widely available. The only contraindication, of course, is contrast allergy. Now, this is a case where we see a dense right MCA. Luckily, we have both sides to compare with. There is a hypodense, you can see here, insular region as a consequence of the occlusion. On the CT angiogram, you can see the abrupt cutoff here of the M2 segment of the MCA, and at the same time, you can do perfusion imaging. This is mean transit time, which has been seen here. And then for detection of the core and penumbra, something which MR used to be very good at, using perfusion and diffusion weighted imaging, even CT is able to show the core, a large infarct core. We need to detect this because patient is unlikely to benefit from endovascular therapy, and this can be assessed using the aspect score, which we'll talk about. Penumbra, of course, we all know in this enlightened audience is assessed either using MR perfusion or CT perfusion, and strong advocates for using CTP to select patients for endovascular therapy. It's important. You need to know what is the volume of brain that is at risk. And recent evidence has shown that CTP is inappropriate in an individual patient, arguing that the error bars associated with noisy processing algorithms are large, but yet it is being used on a daily basis. The cerebral blood volume and the cerebral blood flow are used to differentiate penumbra and the core infarct. The core shows increased mean transit time and time to maximum, markedly decreased cerebral blood flow, and markedly decreased cerebral blood volume. So in this, please note that the CBF and the CBV are both markedly decreased in the core, whereas in the penumbra, even though the MTT is increased, the RCBF is only moderately reduced, whereas there is near normal or increased CBV. So it is the cerebral blood volume which we make use of to differentiate the core from the penumbra and the tissue at risk. These are normal perfusion parameters. We know that perfusion in the gray matter is different from that in the white matter, and these are the normal routine. This is a large MCA infarct where we can see this is the cerebral blood volume, the cerebral blood flow. You can see that they kind of match each other. There's hardly any mismatch. The mean transit time and time to max, all of these can be seen. And here what we see that there is hardly any penumbra, and so most of it is the core, and this patient is not going to do well with thrombolytic therapy. This is a patient with acute left-sided weakness where you can see raised mean transit time. The CT is normal, and you see a right internal capsule, posterior limb of the internal capsule is showing infarct with penumbra. This shows raised MTT, low CBF, and this is the subacute infarct seen later, 3 weeks later. We all know about the aspect score from the Alberta Stroke Program, early CT score, which is a surrogate measure for the extent of infarct core, is a semi-quantitative program, quantifies early ischemic changes in the MCA territory on non-contrast CT. This is a 10-point scoring system which systematically rates early signs of ischemia. A score of 10 indicates a normal scan with normal findings, and 1 point is subtracted for each abnormal brain region. A score less than 4 is significant, and this signifies a large infarct core, increased risk of hemorrhagic transformation, and poor outcomes. And aspects of less than 6 is excluded from thrombectomy. This is various parts, the caudate, putamen, internal capsule, insular cortex, M1 to M6, various territories used for this scoring system. We also have a posterior circulation aspects, again a 10-point scores, where each point is lost for each region affected. Thalami, occipital lobes, midbrain, pons, cerebellar hemispheres, all have points, and you can do a systematic grading and scoring of these. Now, for detection of collateral flow, a multi-phase CTA can do a quick visual assessment of collateral flow in the affected territory. 3 scans after a contrast bolus to capture the arterial, mid-venous, and late venous phases. Degree of enhancement of the pile arteries distal to the occlusion positively correlates with degree of collaterals. In proximal large vessel occlusion, the presence of good collateral vessels is more likely to be associated with a smaller core and more salvageable brain tissue, and is a strong predictor of good outcomes. So this is what we have, a site of occlusion here in the left M1 segment of the MCA. This is phase 1, phase 2, and phase 3. Here we see that there are good collaterals that are seen. This is another case, again M1 segment block, where you see that there are intermediate collaterals. Some collaterals are there, but they are intermediate as compared to this case. And this is a third case where on the right side, you have again the M1 occluded and poor collaterals. So those with poor collaterals will do poorer with revascularization. Now, we all know about features of acute stroke on CT, and it does depend on the time between stroke onset and CT examination. We can see the hemorrhagic character of the infarct, the site and topography, and also the diagnostic yield of CT increases progressively, and by 7 days, virtually 100% of infarcts can be seen. Large cortical surface infarcts are not often documented by CT within 3 hours of onset, but nearly 60% can be detected in 24 hours. This is where actually diffusion-weighted imaging on MR can play a good role. Common early signs, the obscuration of the lentiform nucleus, the insular ribbon, and radiologists are pretty much used to seeing and being able to pick up the early signs. This you have the subtle hypodensity at the left insular cortex, which you can see here when compared to the other side, and loss of the insular ribbon, which again you can see. These are subtle signs which can be missed. But then, of course, the hyperdense MCA sign, which all of us are familiar with, and of course, this is the infarct that is seen. This is wedge-shaped acute infarct in the right MCA. This is a subacute infarct with hemorrhagic transformation, and this is CT scan 5 days after a wedge-shaped, very well-formed infarct seen here. A word about MRI, and diffusion-weighted MRI makes the difference. 25 years ago, we introduced diffusion and perfusion-weighted imaging in this country, in our center, and this, in the beginning, was used only for acute stroke, but now we use it all for tumors, for infection, everything. No MR is done today of the brain without diffusion-weighted imaging, but it was for diffusion in stroke that this actually came about. And, there's no time to go into details, but we do know there is diffusion. It appears bright on diffusion, and on ADC maps, it has to become dark. Only then can we say that this is acute infarct. And stroke damage on MR, on T1 and T2, and even flare may not show up even 2 to 3 days post-blockage. But on diffusion, we can see it within minutes of the blockage. Generally, within a few hours, you are able to see it on flare images, but at times you may not see it for days on end. Now, this is a subarachnoid hemorrhage, which is, again, we know this can be picked up nicely and on flare images. And this is acute cerebral infarct on these are old images. What we used to use proton density images, which really are not used much any longer. And these were something akin to flare images. This is a flare. This is a flare T2 weighted image, and that's diffusion. Acute infarct picked up only on diffusion weighted images, and we are all used to. And these are, I think, from 97, 98 that we have these. This is early stroke on diffusion, and this was picked up, I think, within about 35 minutes of the stroke happening. Normal T2, that's diffusion, and this is ADC, dark on ADC. Hyperacute infarct, again, here a radiologist would be able to pick this up, even though it's not bright, but you see there's, effacement of cerebral sulci and the fissures as compared to the left side. But look at what it looks like on diffusion-weighted imaging. This is differentiating acute from chronic lacunar infarcts. This is a patient, multiple chronic lacunar infarcts in an elderly patient, and it's only this infarct here in the cerebellar region and the left periventricular region, which is actually becoming bright on diffusion, dark on ADC, whereas all the chronic infarcts do not show up. And this is the only way that we can differentiate acute from chronic infarcts. A reinfarction in a chronic infarct, this is a patient who has a chronic infarct, came back with similar symptoms, what he had experienced earlier, and it's only on diffusion that you're able to see reinfarction in the same region. Then we also talk of B-value. This is the difference between a good MRI machine and an average MRI machine. Using high B-value, you're able to pick up much larger areas of diffusion abnormality, much larger areas. This is a B-value of 800, and most machines, do not go beyond 800, but this is on a B-value of 1900. We can go up to 10,000 B-value on our 3 Tesla MRI scans.
Sir, sorry to interrupt, sir. We are running out of time, actually.
Yes, just give me a minute.
Okay, sir. Okay.
Also, a word about multiphasic MRI, a word about, the venous infarcts, which we can pick up a venous occlusion very nicely. And these we know show hemorrhagic transformation, micro bleeds picked up on the susceptibility weighting imaging, but these do not matter much in acute stroke settings. And there is increasingly strong evidence supporting the use of MR imaging in acute infarction. A word about vessel wall imaging and looking at characterizing plaques. And here we are able to characterize plaque using specific imaging on MR. This is fat which can be suppressed, and so And then a word also about those plaques which are the culprit plaques and which show enhancement on MR, as can be seen here. The culprit lesion, the culprit plaque shows enhancement. Finally, a word about role of artificial intelligence in stroke imaging, which is, I believe there's a full lecture on it, so I won't go into details, but we've worked in this field, and this is our paper in the Lancet, along with our collaborators. This was the first paper on radiology AI in stroke in the Lancet, published in November 2018, and there are several solutions that are available which can quantify infarcts automatically using artificial intelligence, and I'm sure this will be covered in the later in the dedicated lecture that we have on this. But maybe the radiologist may get taken out of the equation in the months and years to come, and the neurologist, the neurosurgeon, the interventional radiologist are all that will be needed with the use of artificial intelligence. And this is our platform, Caring Artificial Intelligence platform, which provides access to different algorithms all across the body. With that, thank you very much for your attention, and thank you for giving me this opportunity to share my 30 years of MR imaging, 35 years of MR imaging with all of you.
Thank you, Harsh. That was really great. Such a vast topic, and you covered in just 15 minutes. Hats off to you.
Thank you very much, Praveen.
Just one point for the younger generation. So when a patient of stroke comes, what should be the first modality?
CT scan.
Okay.
CT to rule out hemorrhage, because that gives you a window. Of course, it all depends on when the patient presents. If he is presenting after 24 hours, then, the window is lost. So that is where, acute stroke management has transformed. And we have to talk about it as a brain attack, just as the cardiologists are so good in selling it as a heart attack. So it will all depend on that. Maybe if he comes 48 hours later, then you could as well do an MR examination rather than a CT examination. But in that window of opportunity, CT followed by CT angio. If you have a stroke program going, if you have interventional radiologists available, if you're thinking of using TPA even on an outpatient basis, then it's CT.
Thank you, Harsh. I don't see any question from the audience, so I think we can move to the next speaker. Thank you, Harsh.
Thank you very much.
Thank you. Thank you. Good afternoon, everyone. First of all, I would like to congratulate and thank the organizing committee for this excellent event and giving us this opportunity. The next speaker is Dr. Ashish Bindra. She is additional professor in our Department of Neuroanesthesiology and Critical Care at AIIMS. And she has a special interest in neurotrauma and epilepsy anesthesia. She is editorial board member of Neurology India and Journal of Neuroanesthesia and Critical Care. She has published more than 80 articles and written 10 chapters. So now I would like to invite Dr. Ashish for her presentation on the pain management following spinal cord injury. Dr. Ashish, please.
Thank you so much, sir, for introducing me, and thanks to organizers for giving this opportunity to talk about pain management in after the spinal cord injury. Hope my slides are visible to everyone.
Yeah, visible.
So the overview of the talk will consider defining pain, classification of pain in spinal cord injury, various available treatment modalities, and the conclusions. So by definition, the International Association for the Study of Pain describes pain as an unpleasant sensory or emotional experience associated with actual or potential tissue damage or described in terms of such damage. This can be an acute event which is described to be lasting for less than 12 weeks or a chronic event which is described to be lasting for more than 12 weeks and persists despite an apparent lack of ongoing injury. Approximately 60 to 85% of all spinal cord injury patients experience pain, and about 1/3 of them experience severe excruciating pain. This pain can be acute or it can be chronic, and pain is listed among top 5 problems faced by patients after spinal cord injury. So spinal cord injury can be divided into subtypes depending upon the level of the injury and the severity of the injury, which can be a complete injury, a sensory incomplete, motor incomplete, or normal one. So why this is important is depending upon, as we presume that the paraplegics or the ones with complete cord transactions, they don't have any sensation below the level. So if they don't have any sensations, probably they are not facing any pain. And the ones with incomplete transactions, they have remnant fibers and they must be experiencing some kind of pain depending upon what kind of fibers are spared. But the patients who are quadriplegics, they may not have sensation downwards that they complain of some unusual allodynia or some stimulations which are bothersome for them. So both patients with complete and incomplete injury, they present with pain. So if we classify the pain after spinal cord injury, this is a broader classification. Many classification systems have been given to classify the pain. According to the pathology, it can be classified into a non-nociceptive pain or a neuropathic pain, any other pain or the unknown pains. And in tier 2, it can be depending upon the what kind of pathophysiology or the pain generator they have. It can be a musculoskeletal pain, visceral pain, non-nociceptive. And then the neuropathic pain can be further divided at the level pain, below the level pain, or other neuropathic pains. Tier 3 is dependent upon their descriptions or the manifestations, which can be causing shoulder osteoarthritis. Why shoulder osteoarthritis? Like the patients who are quadriplegic, they are wheelchair bound and they tend to use their upper limbs and shoulders more to push the wheelchair. So probably that kind of pain. The patients who are having neurogenic symptoms, they may have constipation, they can have urinary retention, which can cause to pain, and then there can be autonomic dysreflexia headaches. Neuropathic pain can be because of spinal cord compression, ischemia, or central carpal tunnel, and there can be other kind of pain which can be associated with spinal cord injury. So the nociceptive pain, as we assume that in acute pain, which can be because of damage to the bone, ligaments, muscles, or the intervertebral disc and facets, it is located in the region of preserved sensation close to the site of injury, which may radiate. Whereas During chronic period, this can be because of the overuse of some other muscles above the level of the injury and is more common in paraplegic. And there can be muscle spasms in those areas, and these muscle spasms cause severe pain in these patients. So in acute pain, patient typically presents with a spinal cord injury, like this patient has G12 fracture along with the complete spinal cord injury. So this patient may not present with a pain below the lesion, but can have coexisting trauma. And these then like having bilateral pneumothorax, rib fractures, and other associated bone fractures, which can be above or below the level of the injury. And moreover, when they undergo surgery, they again have lots of pain, which is because of the muscle tearing and because of the ligaments and the bony dissection above and below the lesion. Other patients are like these patients which have scapula fracture, intercostal rib fractures, and they present with not only pain but also respiratory difficulties. So acute pain management in these patients is equally important to prevent the chronic long-term pain association in these patients. So the modalities available for acute treatment of the pain, like in this patient, we put an epidural injection, but putting an epidural in these patients is equally challenging, especially if the spine is injured, so a level below or above, difficulty in location of the epidural space, and moreover the challenges of the level of the block achieved by are equally present. So treatment options for these musculoskeletal pains depends upon the type of an injury patients have. And then you have to go for unstable spine fixation with internal or external fixation, symptomatic treatment, which can be the drug-based, which is a typically step-ladder pattern like paracetamol, NSAIDs, opioids, patient-controlled anesthesia, and treatment for the visceral pain, like in patients with having lung contusions, having rib fractures, we can go for intercostal nerve blocks and even thoracic epidurals. These are very helpful in building up the psychology of the patients and preventing pain in patients with spinal injuries. So conventionally, the spinal injuries were, the opioids were the only modality which were very rampantly used intra and post-operative to control the pain, but now the multimodal analgesia states using the other drugs to reduce the opioid consumption perioperatively. So it can be NSAIDs, gabapentinoids, local analgesic, and the neural blockades. Even ketamine is being very commonly used to control pain. And then in the step-ladder pattern, you can go for opioids and NSAIDs. Next is a patient-controlled analgesia, which is very commonly used in perioperative pain. I won't say that this can be used for very, very long terms, but this is a very good modality which can be given intravenous or intrathecal, which consists of a basal analgesic. Most commonly used are the opioids, morphine or fentanyl, and plus a patient-controlled trigger, wherein the patient feels more pain, then he can push a bolus and get an additional bolus of the drug. So there are studies, and this is a systematic review which compares PCA with other normal conventional methods, where instead that PCA patients had lower VAS pain intensity scores. They were more satisfied. They consumed little higher opioids, but there was no higher incidence of complications leading to delayed hospital stay, etc. So the chronic visceral pain in these patients is because of UTI, bowel infection, and renal colic. The nature of the pain is same in paraplegics, but in tetraplegics, it is generally dull, poorly localized bloating or cramping pain. Neuropathic pain, which is a chronic pain and is the most difficult to treat pain in patients with spinal cord injury, can be experienced above the level of injury in the form of complex regional pain syndromes, causalgias, or peripheral nerve compressions, which can be diagnosed on electrophysiological studies and MR studies. At the level, they can be because of the two segment above or below, and usually present as allodynia or hyperesthesias. And again, they can be nerve entrapment or presence of syringomyelia, etc. Below the lesion are generally the phantom pains or the dedifferentiation pains, which are characteristically described as burning, aching, stabbing, electric shocks, often accompanied with hyperalgesias. And these are more commonly seen in incomplete injuries. So it is not uncommon to see such patients who are paraplegic and underwent spinal instrumentation and later on presenting with severe burning pain in bilateral lower limbs. So such cases are very challenging because they are already exhausting on their medical management, and what is required is probably an intrathecal pump or infusion of the drugs. The most importantly, you should always take the history of the patient, and site onset characteristic, elevating and relieving factors for the pain should be considered. Intervening surgeries and treatment should be considered in these patients. Status of spinal instrumentation, especially if you are planning some intervention or minimally invasive pain procedures, should be taken. And then you have to consider the other imaging, electrodiagnostic and diagnostic nerve blocks. Like many of these patients may present with a facet syndrome, which is treatable if you are able to diagnose it well. So the management of neuropathic pain, we know conventionally it's like level 1 is the anti-epileptic drugs, pregabalin and gabapentin are very, very widely used drugs. Then TCAs, amitriptyline and nortriptyline are quite frequently used drugs. And then the opioids, which can be morphine, fentanyl, and their controlled release preparations. Cannabinoids, but we have not experienced using cannabinoids. And the non-pharmacological management can be minimally invasive pain procedures, which includes the epidural intrathecal drugs, stellate ganglion block or the sympathetic blocks for upper and lower limbs, complex regional pain syndromes, peripheral nerve blocks if there is some apparent entrapment. Then spinal cord stimulation, then surgical can be dorsal root rhizotomy, DBS, cordotomy, etc., and other ancillary management like transelectric nerve stimulation, magnetic stimulation. I'll just cover the few ones because of time limitations. So intrathecal pumps are available for these drugs like morphine, clonidine, baclofen. They are more commonly used for neuropathic pains of peripheral origin, but yes, they have been used with good success in patients with spinal cord injury. So this was a patient who presented with immense spasticity leading to pain after a spinal cord injury. So in this patient, a baclofen pump was implanted, and the pump is contains around 50 ml of drug and lasts for 40 to 60 days. And the infusion rates can be adjusted as titration of the patient pain scores. This catheter was placed inside and was confirmed by C-arm imaging. Then another common entity is facet syndromes, and one has to diagnose depending upon the pain characteristics and what nerves can be, what radiofrequency ablation or steroids can be given. This can be common in patients with spinal instrumentation. Then these are the sympathetic blocks for upper limb. It can be the stellate ganglion block or the lower limb lumbar sympathetic blocks, which are drastically change the patient's profile. And then comes the role of spinal cord stimulation. So there are conventional spinal cord stimulators and burst spinal cord stimulators. These newer stimulators are proposed to be good for management of pain in patients with spinal cord injury, though it is not very widely popular, and there are no any randomized controls trial because it's difficult to do, and but it is being increasingly used for controlling pain in spinal cord injury. Then some surgical procedures can also be done, like deep brain stimulation, motor cortical stimulation, cordotomy, and dorsal root rhizotomy. Other supportive treatments include the transcutaneous electric nerve stimulation. These helps in some kind of patients, but probably not very, very effective in spinal cord injury patients. Other things which should be kept in mind are the psychological and environmental contributors, anxiety and depression. So to conclude, spinal cord injury patients can experience multiple types of pains at single time. Neuropathic pain impacts high percentage of patients with spinal cord injury and is difficult to treat. Multimodal approach to management of pain following spinal cord injury should be adopted. We should have an algorithm for pain assessment and management, and multidisciplinary involvement should also have non-pharmacological treatment and should care about the cognitive behavioral therapy. Thank you very much.
Thank you, Dr. Ashish, for a very elaborative, informative talk on this complex topic. Now we can have the next speaker. I can't see any questions, so we can have the next speaker. Dr. Gaurav is there?
Yeah, hello. Good afternoon.
Can I have this? Yes. Dr. Gaurav is the Director Head of Neurointervention at Vedanta, Gurgaon. He has published more than 50 publications, a reviewer of many journals. Area of interest includes acute stroke management and cerebral aneurysm treatment. So Dr. Gaurav, can you go for your presentation?
Sure. Let me just share my screen. I hope it's visible now.
Yeah.
So, thank you, organizing committee, for giving me this opportunity to share this very interesting but sort of forgotten topic. And today we're going to talk about conscious sedation versus general anesthesia when we do mechanical thrombectomy for acute stroke. And as the old adages, we have to believe what the evidence is showing and should not go by anecdotal evidences. So as we all know, in conscious sedation, we are not giving anesthesia, but we are, giving patient some sedative so that the airway remains patent and patient is responsive. The advantages are obvious when we use conscious sedation for mechanical thrombectomy. It's rapidly fast. We are not wasting time in giving general anesthesia. The effect of anesthetic drugs on blood pressure and other hemodynamics is less. And we, of course, are able to talk to the patient, monitor his mental state during and immediately after the post-procedure. The disadvantages are sometimes patient may be very restless, they are moving, and it may lead to vessel perforation or injuries. And sometimes patients can aspirate, the airway security may become an issue. So how do we go about these things? So sometimes it's very smooth. So for example, a right-sided MCA, and I'll just play this video so you can see patient is not moving as we are passing our catheters and wires through. You may actually feel that the patient has been given general anesthesia. They are so cooperative. It's a head rest. Patient's head is tight and it works out well for few patients, and we can do TK3 decanalization and open up these arteries in no time. And the best part is immediately after the procedure, you can monitor whether patient has improved, what's his neurological status. Not always we see immediate improvement, but in this case we did. And it's very gratifying and satisfying to see this. On the other hand, there are disadvantages also. So another case, left-sided, we were trying to do it under GA, and you can see the visibility is a challenge now. Patient is moving all over the place, and we are not able to see clearly. So what happens in these circumstances is things may jump, catheter move forward, and there was a rupture from this artery. And we ended up occluding the artery we were trying to open. So it's counterproductive. And for all these reasons, talks were there that we should start doing this under general anesthesia, because procedure complications related to patient's movement won't be there. And of course, we are able to protect the airway much better. But the disadvantages, as we said, like it induces hypotension, hyperventilation, cerebral autoregulation may be impaired. Of course, it takes some time to give GA, so the procedural time increases, patient goes on ventilator, whether it increases those ventilator-related complications, and you cannot assess the patient immediately post-procedure. So what's sort of what we try to do these days is like we start under endovasc, like under conscious sedation, but if we see pictures like this, that patient is super restless, moving, not cooperating left side, then there's no point doing all this. Then just give general anesthesia, things become calmer, and then you can open these arteries, work in peace, and get the TK3 decanalization. And of course, the debate is mainly for the anterior circulation. When you're dealing with the posterior circulation, the patients will be very restless. And in those, we need a super good patient, and general anesthesia is undisputedly the best. I think the debate is more for the anterior circulation rather for posterior circulation. So what do the guidelines say? We want to believe the guidelines. So guidelines, of course, we want a good ticket 2B or 3 angiographic outcomes. But for anesthesia, it is still to the individualized assessment of patient risk factors. We do not have a clear-cut guideline which says use conscious sedation or general anesthesia. But these recommendations are based on some trials and non-randomized trials and registries. And if we look at them,
This was the first meta-analysis in 2015, and they looked at these patients, and good subset of patients from 2010 to 2014, and they clearly felt that the worst outcomes, the odd ratios, were worst for general anesthesia as compared with conscious sedation. And but there was a caveat that difference in stroke severity at the onset may be there, because for general anesthesia will be given to the patients who are more sick in general or maybe having a worse stroke. So they recommended a randomized trial. There was another retrospective analysis from the large MR clean trial data, and that also shows that if we give conscious sedation, the MRS scores at 90 days tend to be better as compared with general anesthesia. Again, it's a retrospective post-hoc analysis and not intended for that. So that was the problem, that there was a lot of selection bias. We were including patients with bad stroke in GA as compared with conscious sedation. There were no strict anesthesia protocol, and these are all retrospective studies. So the first trial which came out talking about this was the Siesta trial. It was a German study. And when they included only anti-circulation stroke patients, and they found absolutely no difference between the two. So no difference in early neurological improvement, no difference in mortality or morbidity, no difference in the functional outcome. There was a time difference. If you use a conscious sedation, you gain a mean of 10 minutes. But chances of successful reperfusion and even the right-left laterality was not observed. But what was interesting, if you look at the data more carefully, that there was a trend towards GA being better in achieving a 0 to 2 MRS at 90 days as compared to conscious sedation, though the p-value was not significant. And similarly, if you look at the graphs, for subgroup analysis of NHS score, age, sex, whether the patient has received TPA or not, most of the factors were slightly favoring GA as compared to conscious sedation. But again, we do not have a p-value. And that's why there was no difference in the final results. So site of occlusion, right, left, complications, vessel perforations, they were not significant. There were more hyperthermia or hypothermia after general anesthesia as compared to conscious sedation, which is expected. Delayed extubation was more with general anesthesia, which is again expected. But the conclusion was that use of conscious sedation as compared with general anesthesia did not result in greater improvement, and they do not support the advantage of use of conscious sedation over general anesthesia. Then came the N-stroke trial, and again, they looked at all the subgroup analysis, and they found that there was no difference between the two techniques. But there is a caveat: as long as severe hypertension is avoided. So no difference whether you use general anesthesia or conscious sedation, but severe hypertension has to be avoided. The latest trial, and probably the largest, came from the Denmark group, from the Goliath trial, and they again, they did not find any significant difference between the two groups, though again the trends for successful reperfusion were more towards general anesthesia. The reduction in the final infarct volume as well as the 90-day MRS score, there was a trend, but it did not reach a statistical significant analysis. With the shift analysis also, the odds ratio was slightly better outcome was with general anesthesia, and they concluded that the GA did not result in worse tissue or clinical outcomes as compared with conscious sedation. But again, there is a caveat that the GA protocol has to be like that the time for intubation should be less than 10 minutes. And the blood pressure, the systolic blood pressure, has to be maintained above 140 or mean from about 70 millimeters. So that blood pressure thing is important. And they were trying to assess the risk factors, and the blood pressure being one of them, that the blood pressure has to be above 140. And the treatment delay of 10 minutes actually did not translate into significant clinical outcomes. Now there is a question mark whether these neuroprotective effect of the anesthetic agents, whether they play some role, or influence of ventilation on stroke outcome, whether it plays role. We do not have answers to these questions yet. Now, if things get interesting when you put all these data into a meta-analysis, C-STAR, M-STROKE, Goliath, and a Chinese study of a canvas pilot. When you do that, the data becomes much more, and the trends join up, and what they found that it reached a significant level with general anesthesia. So they concluded that for every 7.9 thrombectomy patients treated with general anesthesia, one more patient achieved a good functional outcome as compared with conscious sedation. And all these 4 trials, they were very protocolized in terms of what general anesthesia and how to give it. And of course, the devil is in the details. So the weightage in all those, it was more towards Goliath and CS10, and they were showing trends towards general anesthesia. And their conclusion was specialized neuroanesthesia care. The GA treated patients had better functional outcome as compared with conscious sedation. In a real world, a very recent registry, again from a German center in 2021, they again said for anterior circulation, conscious sedation seems to be slightly better. Right-sided again favors more unconscious sedation as compared to posterior circulation and left side. The odds ratio for good outcome goes down with general anesthesia, and mortality also is slightly more with general anesthesia. So that's a registry. But again, it's again an observational, non-randomized, non-controlled. There is a lot of selection bias. Individual clinical parameters were not assessed. We do not have any information about the sedative agents, needs for ICU, duration of mechanical ventilation, and so on. Though their conclusion was they figured that conscious sedation is better than general anesthesia. So as you can see, you have randomized clinical trials, you have recent observational studies, large, so this is a 6,000 plus observational study, which is published largest so far. So a major challenge, I think what we face in our practice is the non-availability of the neuroanesthetists round the clock in majority of these centers. So we do need these people so that they understand the nitty-gritties of how to give anesthesia for stroke patients. What we typically like to do is start with conscious sedation if the patient is cooperative, especially on the right hemispheric side. Non-cooperative, restless, left hemispheric, left ICA, tandem lesions, posterior circulation, we tend to go with general anesthesia. We are ready to shift to general anesthesia if it's not working out. So while we are trying with conscious sedation, also our anesthetists are ready, keeping things in place, that if required in less than 5-7 minutes, they can give general anesthesia if required. So to conclude, I think we have to figure out what is best at our center, what works best. Do we have the availability of anesthetists, neuroanesthetists? Can they do GA without causing hypotension? Patient safety is of utmost priority. At present, the data does not support clearly one over the other. Both are non-inferior to each other. Thank you all.
Thank you, Dr. Gaurav, for a very elaborative and informative presentation. I think even for conscious sedation, you need anesthetist. Anesthetist is required.
Correct. But for that, you do not.
We have now many of our students going to private setup. They are providing good neuroanesthesia services everywhere.
I'm very sure. I'm very sure about that.
So you have to have anesthetist even for conscious sedation.
Absolutely. So see, I'm talking in general, like so like big centers like Apollo, Medanta, they have specialized neuroanesthesia people also around the clock. But if you talk from the country's perspective, not every center will have them. So I was just referring to that.
And even anesthetist is sufficient, not neuroanesthetist.
Correct.
But it has to be available.
Yeah.
All anesthetists can provide conscious sedation. And
that is true, but they do not understand that there should not be hypotension. So
you have to interact with them, and they can
correct
all the favorable conditions.
Correct.
Main thing is interaction with the anesthetist.
Absolutely.
Thank you, Dr. Goyal.
Thank you, chairpersons, speakers for their beautiful informative session. We now move on to the next session. May I call upon Dr. Sanjeev Dua, next chairperson, who is Senior Director, Department of Neurosurgery, Max Vaishali. Sir, Dr. Sanjeev Dua.
Yeah, hi.
Sir, good afternoon, sir.
Afternoon.
Sir,
hi, Janet Prakash, how are you?
I'm good, sir. Sir, may I request you to please introduce next speakers and just move on?
Yeah.
Good morning.
So can we have the slides for the speakers after this? Yeah, we have Dr. G.D. Singhal, who is assistant professor in G.B. Pant Hospital. And his areas of interest are skull-based surgery, spine surgery, vascular surgery. And today he'll be talking about craniopharyngiomas, which are really very interesting entities, which are actually benign tumors but behave in a very malignant fashion often. And a lot of controversies surrounding their complete management or their etiology or the kind of histopathology. So over to Dr. Singhal for whatever he has to say on craniopharyngiomas.
Good afternoon, sir. Good afternoon, sir.
Yeah, please share your screen.
Yeah. Some technical issues there. Any technical person to help me?
Dr. Singhal, please open your PPT before you share the screen. Please open your PPT, minimize it, then you share the screen. Yeah, now you are visible.
Yeah.
My PPT is visible?
Yes, it's visible.
Yes, sir.
Make it slideshow. Ghanshyam, make it slideshow.
Yes. Yes, sir. May I start? May I start, sir?
Yeah, start, please.
Yes, sir. Good afternoon to respective chairperson and my colleagues. Today I am presenting a surgical outcome of craniopharyngioma. Since ancient time to current scenario, craniopharyngioma is still challenging. No uniform consensus has been made for every case. The surgical approach is customized to individual case to case. In spite of a benign tumor, nearby vascular and hypothalamic structure behave like a malignant. As sir previously said, there have been many advances in the surgical approaches of craniopharyngioma. Still, the outcome may not be as expected since its location and associated challenges. In my series, 45 patients were operated in last 4 years via anterior subfrontal or lateral subfrontal routes. Somehow, retrospectively, 25 patients were analyzed in terms of clinical profile, hormonal status, surgical and radiological outcome. Out of 25 patients, 11 were male and 14 were female. Headache with diminution of vision is a usual common presentation in our series. Hormonal profile was normal in majority of the cases, except two where prolactin is marginally raised. By a lateral subfrontal approach, 22 cases were operated and 3 cases were operated via anterior subfrontal approach. Hydrocephalus and papilledema is present in 22 cases, 21 cases predominantly cystic. Gross total resection achieved in 3 cases, near total resection achieved in 18 cases, subtotal resection achieved in 4 cases, and 4 patients were operated for the recurrence, which was operated outside. Not my recurrence. In post-operative phase, electrolyte imbalance developed in 21 patients in the form of DI and SIADH. Mortality developed in 3 patients. 1 patient was the very huge recurrence is there, and 1 patient is having a uncontrollable DI in post-operative phase, and 1 patient is having a very huge tumor. Hormonal imbalance developed in 2 patients. Attention deficit developed in 2 patients in the form of decreased school performance. Menstrual irregularity developed in 3 patients. Central obesity was developed in 1 patient. Conclusion. Gross total resection should be attempted in every case. Strict follow-up must be essential to avoid postoperative morbidity and recurrence. There is no requirement of BP shunt in spite of gross hydrocephalus. Primary surgery is sufficient, and it can be done as early as possible after detection of the suprasellar lesion and with hydrocephalus. Hypothalamic injury is so common in gross total or near total resection. Large tumor is having poor prognosis. Lateral subfrontal approach is generally safe, and its following advantage: it is more familiar to the most of the neurosurgeons, and systems are early available in this approach. Sylvian fissure is early visible in this approach, and it is the shortest route provided in this approach and in the suprasellar lesion. Multiple surgical corridor and bimanual techniques should be used to safe resection of the tumor. This is the opticocarotid system and opticocarotid surgical corridor. This is the interoptic corridor, and this is the carotid oculomotor corridor. We have used all three corridors to deliver the tumor. In all patients, we routinely advise radiotherapy except when the gross total tumor resection is achieved. There is no recurrence reported in my series because of the short follow-up, just 4 years follow-up. One prototype case is a 50-year male patient presented with a headache and diminution of vision for last 6 months. On examination, except early changes of optic atrophy, no neurological deficit is there. On endocrinological investigation, there is within normal limits. On contrast CT scan, there is a hypodensity in the suprasellar area is there. On MRI, there is a cystic lesion present in the suprasellar region, and on sagittal MRI, contrast enhancement is there in the suprasellar area. After drilling the ACP in lateral subfrontal approach, we routinely drill the ACP and open the Sylvian fissure. After drilling the ACP and durotomy, we open the Sylvian fissure widely. The opening of the Sylvian fissure is basically two advantages. It later on requires less brain retraction, and there is no requirement of almost negligible requirement of brain retractor. After opening of the Sylvian fissure and identify all structure, we aspirate the cystic content of the craniopharyngioma. That's why spillage is not there, and after aspiration of the cyst, tumor will lose out from the surrounding structure and delivered easily. Craniopharyngioma is almost mildly vascular or avascular tumor, but due to associated hypothalamic perforators and association of the posterior pituitary or hypothalamic structure, it behaves like a malignant. During the delivery of the tumor, we constantly visualize the normal structure. This is the post-op scan of this patient, and there is the complete removal of the tumor without any obvious hematoma. The take-home message is there. The drilling of ACP is essential in almost every cases, and fissure open widely. That's why brain retraction is minimal. So, multiple surgical corridor like interoptic, opticocarotid, and carotid oculomotor system should be used in almost all cases, and avoid spillage of the cystic content. We routinely aspirate the cystic content, and due to aspiration of the cystic content, we easily deliver the tumor. Next slide. I think video is not, due to some technical issue, video is not visible, and I conclude my presentation. Thank you, and open for discussion.
Yeah, General Prakash, your comments? You have to unmute your phone. Your system is on mute.
My system?
No. Tell Prakash's system is on mute. Pragyan. Yeah.
Dr. Ghanshyam, is a nice presentation. I mean, what I wanted to ask is your strategy in recurrent tumors any different from primary tumors?
Usually we use the different corridor. If we previously use the lateral subfrontal, then we go again in recurrent tumor, we can go for, we should use the anterior subfrontal route. Different corridor.
No, it is, sorry to interrupt you. It could also be like, where is the actual, the approach can also be, planned according to the tumor. In which direction it is going, in which parts it is involving, whether it is more on the left side, right side, or, that can be.
If the tumor is more on the right side, then we go for the right subfrontal, right lateral subfrontal, right tegmental craniotomy. If the tumor is in the midline and go and bend to the lateral most to the subfrontal, anterior subfrontal, then we go for go from the anterior subfrontal approach.
You mean to say that you will choose a different route, not the same route, maybe secondary to sedation, adhesions or something like that? Is that you wanted to convey?
Pardon?
Adhesions, or you want to choose a fresh route? You want to say?
We should choose the fresh route if the recurrence is there. Because so much gases is there and adherence of the surrounding structure, we facing so much difficulty in the previous route.
Dr. Ghanshyam, hello, am I audible?
Yes, sir.
Yeah, audible. Yeah,
audible. I just want to know what is your this lateral subfrontal approach? I think it's you mean terional approach, no?
Yeah, yes, sir. Yes, sir.
Yeah, that's one. Secondly, while dissecting, it is already brought out how the tumor layout is there. But important is that there's no optic nerve or chiasmal injury and vascular injury, and at the same time that we try to look for the infundibulum, otherwise infundibulum injury is there. So these are the restrictions which we generally follow. So it's a good presentation. It showed some cases where complete removal has been done, but it is the follow-up which decides. Operatively, it looks it's all right. But despite complete removal, and all the tumor don't come. So if you find a plane, we go ahead. If you find difficulty in plane, then probably we'll stop.
Then we cannot achieve the gross total resection.
Yes, thank you.
Dr. Ghanshyam, one last question. Any comments about use of bleomycin or interferon or other drugs sometimes being used these days? Anecdotal reports, not proven, but yes. In fact, I've also used them sometimes, and I sometimes feel that bleomycin may have a role to play.
Yes, sister.
Unfortunately, I have not the experience of the using of the bleomycin or.
Right. I mean, it's not a accepted or a universal technique to be followed.
Yeah, it's right. Some people do use it in cystic craniopharyngioma. Put a
Ommaya
reservoir and it works. We have seen some patients who do well.
Yeah. No, I mean large series. We don't have such large series, so I was just trying to see if they got a large.
Anecdotal.
They would have some more information on this. I think now we can go to.
No, we have but one. I think I remember only one case who was reluctant for surgery and he opted for this. Not much large series. No.
Right. Let's go for the next presentation now.
Yes, sir.
Anita. Yeah, Anita is a professor, Department of Neurosurgery at GV Panth Hospital. I've known her since she was a student and still appearing for her MCH, and now, of course, she's gone places, and she is now a well-recognized figure in the field of neurosurgery, especially neurovascular surgery. And today, her topic is surprisingly on Pott's spine. It's a topic which a lot of people do not want to talk about because it seems that everything that to be discussed is already done and over with. But every now and then we are confronted with situations which probably need more than what has already been decided. So Dr. Anita, please share with us your experiences with POTS cervical spine.
Morning, sir. I'm just connecting. Some problem has happened to my connection. I'm just reconnecting it. Just give few seconds.
Yeah, sure. Go ahead.
Yeah, thank you, sir. हमारा कौन सा है? Which one is yours? Okay.
Anil.
Yeah. Am I audible?
Yes.
Yeah. Yes, please, sir. Good afternoon, sir, and good afternoon to all. Please. Is the presentation visible? Hello.
Yeah, go ahead.
Yeah, thank you, sir. So my topic is cervical POTS spine. Is 360-degree fixation mandatory? I'm talking on this because with the two main objectives. One is which cases require anterior fixation only or both anterior and posterior fixation. And is expandable cage is a promising implant for anti-interbody fusion in these cases. We all know we classify the POTS spine in 4 categories. Yeah. So we have 4 types of POTS spine, which involves spine in different ways: paradiscal, central type, posterior type, and non-osseous type. In paradiscal type, there's involvement of the part which is adjacent to the disc. Disc is avascular in adults. So the perichondral vessels, they divide, bifurcate here, and they become the source of the infection. That is how the infection goes hematogenously to this area. Centrum type involves only the body. The posterior type involves posterior elements, sparing the elements, and non-osseous type, there is only the abscess formation is there, which can be as extensive as involving.
There's some problem.
Yeah, with the sound, yes.
And there's
Dr. Anita, your sound is non-comprehensible.
This is the peridiscal reach of the disc. This is and not responding to the antitubercular medicines. This reaches this and kyphosis happens. Is it fine now, sir?
Yeah, it's
much better.
It's better, right? Okay. So this is the stage where when finally it reaches, if it is not treated and controlled, disease is controlled, it reaches to the spondylodiscitis level where there is involvement of destruction of body, abscess accumulation in the prevertebral space, in the subligamental space, and there is kyphosis because of the facet dislocation. So these are the various bony involvement which can happen in any patient. You may find individual bony involvement, and there can be combination of all the bony involvement, like fragmentary, or it is only limited to the body end plates. It can be osteolytic, or it can be localized with the sclerotic element. This there are different radiological signs which can say that, which can predict that this patient will have unstable spine in the follow-up. One is separation of the facet joint, which can be appreciated on the X-ray and CT as well, that the distance between the two facet joint will be increased, adjacent facet joint. Then it can be retropulsion of the vertebral bodies. In the coronal plane, there can be lateral translation of the bodies, and they can be toppling. So what is toppling? This is involved segment. So the body, normal body above the involved segment, and the normal body below the abnormal segment, their anterior parts, they are in contact with each other. That is toppling, and this leads to kyphotic deformity. So if we see this progress of the disease, how the tuberculosis in spine progresses, there can be minimal destruction of the alignment, and just wedge compression of wedge decreased thickness, height of the body. But if it progresses and not tackled in time, this can lead to destruction of the body, and the normal body above can touch the normal body below in the middle of the body. This will lead to kyphosis, and this kyphosis will be limited to around 40 to 60 degrees. But this can progress to type C spine, where there is complete destruction of the involved body, and the upper edge of the normal body that touches the lower edge of the anterior border of the normal. Here both the anterior edges are touching. Here the anterior edge is touching in the middle. So there is some contact of facet is there, but if it is more than 50% contact is not there, it leads to instability. So we did around a couple of cases in a 1 month's time in the COVID period last month only, and I'm showing all those cases and what lessons we learned in these cases. This was a 60-year-old male, a 60-year-old man who was daily wager, and he had neck pain for 3 months, which was associated with the painful neck movements. He had spastic quadriparesis, which was more on the right side, without any other symptoms. This patient had involvement of 3-4-5 cervical 3-4-5 vertebrae, and you can appreciate the abscess was so extensive, right from the C1 and going down, and there was prevertebral collection in along whole of the spine with destruction of body. There was subligamentous intradural collection and canalicular compression, the spinal cord compression, dural compression. On CT scan, we can appreciate all forms of CT appearance of the what we see in the pot spine, that is fragmentary, osteolytic, subperiosteal, and even the localized type also. So considering this, he had this, there was facet dislocation, and the lordotic, this curvature was lost, and there was around 50-degree kyphotic angle, and this constituted as a type P reconstitution of the pot spine. So we thought we can do decompression and we can get away with the simple putting the expandable cage. We did the expandable cage, put the screw with the expandable cage without plate reinforcement, and this kyphotic angle reduced from 50 to 10 degrees. Very happy with seeing this scan, but after a few days at the time of discharge, we got the X-ray done again, and we found that there was extrusion of the implant. So we thought that we'll not put the cage, we'll not put the implant because he had extensive abscess. So we thought that we'll put minimum of the metal implant. So we took the fibular graft, but fibular graft, for knowledge of the youngsters also, that fibular graft is not a good graft now because it is not an osteogenic graft. It has no marrow inside. So we took the graft unknowingly that it will not have marrow. When we saw that there was no marrow, we got to know that fibular graft is not an osteogenic graft. So finally, we took the mesh cage because it was 3-level. We put the mesh cage filled with the fibular graft and the BMP, and did the anterior plating and the posterior fixation as well. And this patient went home, and surprisingly, this patient had extruded implant, but still patient had no neurological deterioration. So this was another case, which was a 22-year-old girl, young girl, who had neck pain again for 2 months with weakness. And this girl was on ATT for 2 months, still she did not respond. And she was quadriparetic, but she was ambulatory and with sensory level of D1 below. This was our MRI. Again, you can appreciate that this abscess was extensive. It was not localized to the level of the bony destruction, and there was lytic lesion also in the adjacent vertebral level. This patient was operated just by doing anterior fixation. This was, since it was 2-level. It was 2-level. The previous case was 3-level. This was 2-level spine, 2-level body involvement, cage, titanium cage with anterior fixation. And you can appreciate the good alignment of the facet joint. This was the case where facet joint alignment is quite good. This can be appreciated in X-ray, but nowadays most of the time people are doing the 3D reconstruction of the facet joint just to see the facet, just to see the orientation of each of the facet. This is another case where there was type of reconstituted spine, where there was a destruction of this whole body, and this upper body is lying in the upper body, normal body is lying in the middle of the lower normal body. There's collection here, subligamentous collection, and the posterior dura is also enhancing. This is a CT scan of the same patient where there's destruction of the body, and there is facet joint dislocation as well. Again, same, all kind of bony changes one can appreciate in these cases. Anterior fixation and plating was done, and quite good facet joint alignment was achieved. Another one more case where only anterior fixation was done. So in all the cases where 2-level fixation was required, we just did anterior fixation. Any case which was requiring more than 2-level, we finally had to perform 360-degree fixation. So few salient features about expandable cage. It is very easy to implant the expandable cage. There's less risk of damage to the end plate because you're not using hammer to put the cage inside, as is done for the mesh cage, titanium mesh cage. There's less intraoperative manipulation when we are putting the expandable cage, and it gives you better control on lordosis compared to the mesh cage. And it is very good in poor bone quality, like patients with osteoporosis, with patients with metastatic tumors who have been subjected to the radiotherapy. But their disadvantages are it is associated with, it can be associated with over distraction. And if it is over distracted, there'll be less surface area available for diffusion. And of course, cost is a very big issue. So this was the meta-analysis which was published last year only. And this meta-analysis, they studied 76, they found these 76 different studies as their criteria, eligibility criteria. And in this study, 138 cases were enrolled under the expandable cage group, and around 89 patients were under non-expandable. So there is an increasing rise of trend of using the expandable cage in cervical spine surgery. In these two comparison, they were 1-level or 2-level. There was no 3-level comparison was made. And the outcome was assessed by change in the segmental lordosis. And they found that mean change in segmental lordosis was statistically significantly more in expandable cage. However, this was associated with significantly high revision rate in the expandable cage compared to the non-expandable cage. And the clinical outcome was poorer in expandable cage than the non-expandable counterparts. So at the same time, combined anterior and posterior fusion provide significantly better stability, but it leads to restricted cervical range of motion. So you need to balance between the two, which case requires 360-degree fixation, which case can get away by just doing the anterior fixation, stabilization, and decompression in these cases. So to conclude, although expandable cages are clearly beneficial in certain clinical situations, the use of it should be justified that what kind of surgery we are doing. If we are doing the osteoporotic degenerative spine, where the aim is to do complete removal of the posterior element of the body, including the ossified ligaments, there we can definitely fit in this cage nicely, and preferably for 2 levels. And if we are using the cage, which type of cage we should use, what should be the diameter of the expansion which is happening, and what quality expandable cage we have. There should be spicules in the cage which can go and adhere into the end plate, which will prevent the extrusion of the cage, and that should be enforced by applying the plate if you are using for 2 levels or more than 2 levels in select cases. 3-level involvement definitely needs 360-degree fixation, and up to 2 levels vertebral involvement, only anti-fixation should be able to stabilize spine better. However, these cases should be kept in follow-up to see the progression and the fusion in long term. Thank you. Stop sharing.
Hello.
Yes, sir. Hello.
Dr. Anita, very nice paper. It invokes your thought process, what should be done in individual case. That's right. But what I want to note is what is the cause for failure in expendable case. One is that in expendable case, the amount of bone which you put is less, but you use BMP predictability of how much bone it will form remains the issue. So how to go about it?
Yes, sir. Actually, if we see that in this particular case, the upper limit was C2, and the facet joint orientation of C2 is definitely different from the subaxial spine. So that orientation was different because it was C2 to it was the screw was going into the C2 and down into the C7. So that disparity was there. That was one point. Second, it is in tubercular infective spine. Our aim is not to do the complete removal of the bone. You remove the uncovertible joint, both laterally, because in many cases you find that it is destroyed. The joint is also destroyed, and you may land up into the foramina also. So main idea is to decompress adequately and put the graft. And because it was 3-level, so we over distracted the cage. So that was the reason. And secondly, it was not supported by the plate, onlay plate. We just put the screw into that. And thirdly, if we had done in the first go, because it was 3-level, if we had gone in the beginning, the posterior fixation as well, that would have given us.
Thank you. I think we'll open for any.
Union is not as good as in expandable case because you're not putting much the filling of bone is not good.
Thank you. We can open the paper for any comments or questions.
One comment: we had started using expandable cages when they were first introduced from Medtronic, and our problem was that the locking mechanism was not that great. And these expandable cages, when you put in a plate along with them, sometimes these cages would collapse because the lock would just unlock and the plate would remain in place and the cage would become smaller. That gave rise to certain problems. So that was one issue which we raised with them, and probably now these guys are not producing those kind of cages anymore. And now you have cages which have got a plate inbuilt into them. Maybe that obviates that problem. And of course, as Dr. Prakash said, that the amount of bone that we use within the expandable cage is limited, and that may have a problem with the fusion. Of course, supplemented with BMP, we can overcome that. Any questions from the house? I think there are none. Then Anita, thanks for a good presentation. And I think we can go on to the next part of the session.
Thank you, sir. Thank you.
Thanks. Yes, Prakash, go ahead.
Okay. Brigadier Shashi, hello.
Sir, good afternoon, sir. Can you hear me, sir?
Good afternoon. Nice to see you.
Sir, same here, sir.
Okay. Please go ahead with your presentation. Shashi is neurosurgeon. These days you are in Bangalore?
Sir, no, sir, presently now in Bathinda, sir.
Bathinda, okay.
I'm presently in Bathinda, sir.
Okay, right. So he's got a, I think you're something on AI, no? Artificial intelligence?
Yes, sir. I'm actually speaking
Yeah.
on
Okay.
extremely minimal English.
This is a new field which is coming. Let's listen to him. Over to you, Shashi.
Yes, sir. Sir, I hope I'm. Can you see the screen, sir?
Yes, we can see. You can zoom it.
Yes, sir. Yes, I'm doing that, sir. Now is it visible, sir?
No. We
can go to slideshow mode.
Slideshow. Yeah.
Yeah, I think you can go this way also.
Okay. Otherwise, you can go on slideshow.
Continue with one by one.
Can I help you?
Okay. It's all right.
Doctor, just click on slideshow mode.
Is it okay, sir?
Just next to that.
Now is it okay?
Yes.
Yeah.
Go ahead.
Is it okay? So first of all, I would like to thank the organizers of the DNACON for inviting me for this, for giving me this opportunity to present my work. My salutations to General Prakash and Professor Dua. Coming to the history of nanotechnology, the father of nanotechnology, Richard Feynman. It's not a field which is more than 50 years old. Nanotechnology is 1 billionth in the SI segment of a SI unit of a meter. Nanotechnology, actually more than 2000 years ago, the Greek used to use it as sulfide nanocrystals for the hair dye. Since then, the technology has advanced. The coined term was by Norio Taniguchi in 1974, then started the atomic force microscopy. And by 2000, National Nanotechnological Initiative was started. After that came in the robotics from 2005 to 2009. In 2015, the global market for nanotechnology reaches $1 trillion. Presently, it is supposed to be around 4 times by 2028. So an estimated 6 million workers will be needed worldwide for the molecular assembler to be developed. Coming to the evolution of neurosurgical techniques. Neurosurgery began as a specialty where the surgeon was focused on excision of tumors, removal of ruptured discs, or fixing an unstable spine. Subsequently came the neuroendoscope, interventional radiology, and later stereotactic surgery. The neurosurgeon who so far relied on the tactile and the visual feedback is being pushed by newer technologies which rely less on primitive feedback mechanisms. I call them primitive because now we have to rely more on the other newer technologies. So what is nanotechnology? Nanotechnology can be defined as the science and engineering involved in the design, synthesis, characterization, and application of materials and devices whose smallest functional organization in at least one dimension is the nanometer scale, or 1 billionth of a meter. So that's very small. So aim of this presentation is to enumerate the research work which has been carried out in the field of nanotechnology, which will have a potential to enhance the practice of neurosurgery. Exciting field of research going on in the field of nanoneurosurgery, nanoimaging, non-surgical nano repair, nano neuromodulation, and nanobiotechnology, all the nano robots. What is nano manipulation? Surgery at the neuronal level involving the cell processes or the intracellular manipulation. Nano knife is with a 40 nanometer diameter knife which has been developed for the axon surgery. Following control transaction, axons can be maneuvered into position using dielectrophoresis. So, coming to axon manipulation, the nanoneurosurgeon will have to rely on the optical microscopy and electron microscopy to visualize the axon before doing any kind of manipulation. This is how you see a single myelinated axon in the photomicrograph. So the axonal repair, as far as the neurosurgical the schema is concerned, is divided into 3 stages. The single axonal repair is done in 3 principles. In stage 1, we have a nano knife, which is around 20 to 40 microns in thickness, and the mechanical compliance of the suspension can be modulated. Once the entire system of cutting and manipulation is done by the micro electromechanical system, which eliminates the need for manual manipulation. The process can be initiated following onboard sensing devices, which take over the function of on a semi-autonomous manner. This is how the experimental device looked like. The studies have been carried out in California, wherein what you see in the center, which is marked K, is the knife. The suspensions are on the sides, and this entire chamber is in a 1 square millimeter area. This tip is, you see at the tip of the nano knife, which is to cut the axons. Here you find that the axon which has to be cut is slowly progressed towards the nano knife. This is the nano knife which has been cut. Here you see the myelinated and the unmyelinated fiber which has been transected with the nano knife. In the stage 2, once we have cut, this aligning the cut ends in a precise manner. Contact or non-contact methods are used. The challenge lies in manipulating without altering the function of the axons. So the most commonly used method is the dielectrophoresis non-contact manipulation. And what is dielectrophoresis? Basically, what you have is there are 2 electrodes. One is C-shaped and one is a straight electrode. In between, you find is the nanofiber, the axon which has been cut. And by passing small electrical currents between the 2 electrodes, the cut ends are manipulated so that they come to approximate each other. The stage 3 is fusion of the cut ends, which can be achieved by polyethylene glycol, by laser-induced fusion, or by electrofusion. So pairing of the DEP with the electrofusion simplifies the 2 stages of axonal surgery, wherein the same electrodes can be used for stage 2 and stage 3. So in the schematic, one has to see what is happening is, you can see that this gray area in center is the part of the injury, wherein this injured part of the axon has been removed, transected, and the donor axon is replaced into this place. By manipulation, it comes into alignment, fusion which takes place, and the continuity of the axon is resumed. Now, once we have resumed the continuity, it's a structural thing, but one has to see the function. So for the function, it can be ascertained by green fluorescent protein, which confirms the axonal continuity. GFP, when you find that this slide, if you see A, C, and B, D, without the fluorescence, you find between A and D that the structure is there, but the continuity, functional continuity is not there. But within 20 minutes, you find that the axon which has been connected, there is a continuity. As you can see, the GFP, the fluorescent protein, which is flowing from one side of the axon to the other. So this one proves that after the axonal surgery, the continuity of the axon also is restored. Now, how does a micro electrical mechanical system look like? This is what it is the size. It is around 1 square millimeters, 1 cubic millimeters in the size. Inside, there are various electrodes, the cutting device, and this is the entire system which does the cutting, the manipulation, and also the fusion. If one has to see it on a larger scale, in a more schematic way, this is how it would look like. The pink side is the host axon which has been damaged. This is the donor axon which is there. The various axons are coming in alignment, and this is the MEMS system which is placed over them with a micro positioner. And this is the action repair platform. Also, what you would like to appreciate is there are fluidic ports which are on both the sides. These give you the neurotropic factors which help in healing and regeneration. What are the challenges? It may look very simple, but it is a very challenging field, because to set up all the core technologies is to make it has to be of practical use in the CNS repair. So far, the repair has been going on in the peripheral nervous system, but in the CNS it is more challenging. One needs to carry out repair in a coordinated and a sequential manner. One has to control the microfluidic environment, and optical monitoring is required to see that the manipulations are being done as per the sequence and as per the requirement. So the seeded cells and growth factors require a 3-dimensional bioscaffold, which supports all stages of regeneration, providing revascularization in addition to providing mechanical support, and to offer tangible benefits. Each stage of surgical repair and regeneration should follow a favorable sequence. This will require constant monitoring and intervention. So that was about the nanosurgery. Now coming to nano neuroimaging. Gold nano cages are used in photoacoustic tomography. Now photoacoustic tomography is the standard imaging along with acoustics, wherein because of the current, the electrical, the magnetic current is transferred into a acoustic mode, which is detected. And it provides three-dimensional accurate imaging of the tumor, and even blood vessels or the tumor up to the clarity increases by 50 times to a depth. Then we have the quantum dots. The quantum dots targeting the epidermal growth factors. If you see that, if you add the quantum dots in the case of GBM, the part which is lighting up is showing that the tumor is there. But the center part, which is black, where there is no quantum dot, means that there is a complete, at that place, there is no tumor. Now we also have got the super paramagnetic iron oxide nanoparticles, which help to distinguish pseudo progression from tumor progression in patients with GBM, where it's a common problem. After the surgery, one is not sure whether it is pseudo progression or it is a tumor recurrence. The detection of nitric oxide has a number of physiological functions. It has been implicated in many vascular pathologies. So the platinum nanodiscs are used for multidimensional imaging. Also, the nanoparticles are used in tracking the stem cells with MRI imaging. Non-invasive detection of neural progenitor cells, living brains by MRI imaging is enhance the brain delivery of blood-brain barrier, which are impermeable to the optical and MRI images. So now what is being proposed is a trimodal imaging of tumors, which involves photoacoustic, Raman, that is a spectroscopy, and the conventional MR, with or without the quantum dots to facilitate more accurate tumor characterization and resection. Coming to nanorobots. Nanorobots would constitute any passive or active structure capable of actuating, sensing, signaling, information processing, intelligence, and swarm behavior at a nanoscale. So nanorobots and nanotechnology. Miniaturization of devices from microelectrodes to nanoelectronics. Nanorobots with embedded nano biosensors and actuators is opening up vistas for early detection of brain aneurysms. The philosophy is nanorobot prototypes developed which can detect cerebral aneurysms. It has embedded nano biosensors for detection of nitric oxide synthetase. And the nitric oxide synthetase overexpression with telemetry control and data transmission gives a fair amount of reliability of areas which can lead to formation of aneurysms. So this one would tell you where the aneurysm is structurally going to come up in the brain vasculature. So in body sensors, there are in-body sensors which can check for abnormalities, kill pathogens, repair and protect structural and functional abnormalities even before the patient manifests symptoms. So there's a very significant difference wherein from the treatment aspect, we are going more towards the preventive aspect of neural conditions. Nanoelectrodes are electrodes which are the nanoscale, which are very small, which are roughly that of molecules, which can go up to the molecular level. This improves the order of magnitude and helps the monitoring at the neuronal level. They can be grown and modified to support growth of the neural networks. So it is understandable the size of the electrode, the smaller the size of the electrode, the more specific it is to one particular neuron. So therefore, the precision is increased. Nano neuromodulation is set to make procedures of deep brain stimulation more precise and effective. Nanoscaffolds. Now these structures provide support and promote growth and differentiation. Like in the previous part I had showed you, wherein by nanosurgery one can operate and reduce, get the continuity of the neural structures. But these structures require support, mechanical, and also they require blood supply. So for the support, we have got the nanoscaffolds, which are self-assembling peptides nanofibers, which assemble into interwoven nanofibers. And these later on, they degenerate. The nanoscaffolds also enhance the neural stem survival in 3D cultures. They enhance the osteoblast proliferation. They possess hemostatic properties. They are slowly metabolized without any toxic or native toxicity to the tissue. And these properties make them ideal for use in neurotrauma, especially in spinal cord injuries. From macro to micro to Nano excision is what we are seeing over the last decade. As nanotechnology forays in neurosurgery, demarcation between science and fiction is getting progressively blurred. The neurosurgeon of future needs to be tech savvy, understand and accept newer technologies which are changing the very philosophy of neurosurgical practice. There is a transformation from macro excision to nano excision, mechanical to functional repair, and from clinical diagnosis to molecular diagnosis. So to conclude, medicine seems to be transforming from prevention to cure to intervention and prevention at the cellular level. This field of transformational medicine will involve coming together of multiple stakeholders from diverse fields. You would have the neurosurgeons, the neuroscientists, the physicists, and the electronics. The focus is to make humanity disease-free and probably immortal in the near future. So to conclude and to thank everybody, nanotechnology in medicine is going to have a major impact on the survival of the human race. So with that, I conclude my talk. Thank you, sir.
Thank you, Brigadier. Hello. Thank you, Brigadier Shashivardhan.
Sure.
This is more of a futuristic thing which is maybe on the horizon. So is it anywhere it is in clinical use?
So far it is only in the experimental use. Users have been shown in the peripheral nervous system.
Yeah,
and like in the sciatic nerve, they have done some studies. As far as the brain is concerned, some studies have been done on the mice models in the optic nerve. So the optical continuity they have assumed, but the functionality has not been very good.
Okay, thank you.
They're still working on it, sir.
Okay, Dr.
But it's an
Sanjeev.
exciting field and it holds a lot of promise.
Dr. Sanjeev,
Yeah,
over to
Shashi.
you. Over to you.
Shashi, I had my chances with nanotechnology. I was associated with this project with Delhi University a long time back, but then we shifted to private and that went away. Anyway, two things. If you remember, as medical students, there was a movie called The Fantastic Voyage. I don't know how many of you have seen it, but then in that movie itself, you could see what is being talked about today in nanotechnology, and they had actually projected all those images in reality over there. And two comments only. One, of course, is that as far as practical uses are concerned, the drug delivery systems are being developed, which can give targeted drug deliveries across the blood-brain barrier, and chemotherapeutic models, experimental and even now on human scale, are being developed.
Yes.
And second thing is, you had said that things will be done under electron microscope. Electron microscope will not be able to see living tissue at all, because electron microscope has to see a dead tissue. So these are photon microscopes which are being developed to do this.
Yes, sir. Yes, sir. Yes. I agree with you, sir. There are photon microscopes which have got very high magnification, and the manipulation can be done under the photon microscope. You're right.
Yeah, right. Great. Thanks. Thanks for the presentation.
Thank you, sir.
Shashi, thank you. Thank you very much.
Thank you, sir.
We move to the next presentation. Dr. Sanjeev, can take over.
Yeah, Pragyan. I think Pragyan will take over this and he will be talking about neuroendoscopic extended approach for plenum sphenoidal meningiomas. Pragyan is in UCMS. Of course, he joined after I had left, but then we have communicated often enough that I seem to know him personally. Over to you, Pragyan.
Yeah, thank you, sir. Thank you very much. So I hope the screen is visible and I am audible.
Yeah.
Yeah,
very
thank you.
much.
So this presentation is all about extended sphenoidal approach for the excision of tuberculum sella and plenum sphenoidal meningioma. Now, the skull-based surgery has progressed significantly over the recent years with the advent of modern imaging methods and also newer instruments and also advancement in the overall technology of a neuroendoscope. Now, this approach, extended endoscopic approach, is a very versatile approach, and the particular advantage of this approach is better visualization with minimal collateral tissue damage. Also, the recovery is quicker than the conventional open approaches, and also the preservation of the nasal anatomy and function can be easier with quicker actions in case revision is required. This category of meningiomas presented in this series constitute a very minor proportion of the altogether meningiomas seen. but these are very challenging tumors to operate in view of their proximity to critical neurovascular structures, and they can challenge the skill of the treating surgeon. The main advantage of this approach for these meningiomas are early visualization of the tumor. Tumor debulking can be done without manipulating the optic apparatus. It can provide direct access to the medial optic panel, and also it is minimally invasive. So the endoscopic approaches, the stage basically can be divided into 3 stages. The initial part, of course, consists of appreciation of the normal anatomy. It is for the operating surgeon, it is very important to be aware and fully aware of the normal anatomy. This is the septum, this is the normal anatomy of the septum. It is important to appreciate the relation of the nasal bone and humor, which helps in surgery. And also laterally, the most important structure is the middle turbinate. However, from surgical perspective, it's important to know and to appreciate all the structures as seen in this cadaveric dissection. Now, this is the initial intraoperative view of the nasopharynx, where the superior limit, the lower limit, and the sphenoid ostium can be easily seen by deflecting the middle turbinate medially. As you can see, this is the sphenoid ostium, which is a very important step in the surgery. Now, though the middle turbinate is very important, it is very important to appreciate that the middle turbinate can have attachment to the skull base, and therefore manipulation should be done very carefully. And undue manipulation of the middle turbinate can lead to fracture of the attachment of the lateral lamina of the cribriform clave, which can lead to CSF leak if not carefully done. So these are the surgical trajectory in relation with the middle turbinate, this structure, and this here the blue line is the anatomic and landmarks while approaching the anterior wall of the sphenoid septum. Now, from surgical point of view, it is also important to be aware of the nasal anomalies like the septal deviations, the inferior turbinate, and also the most common anomaly here is the deviation of the septum and a septal spar, which can cause confusion. This is a typical picture of the septal spar, where you can see this is a septal turbinate, which can again be a cause of illusion and mislead the surgeon as having entered the spinal septum. These are the anomalies of the turbinate. As you can see, there can be inferior turbinate hypertrophy, there can be turbinate concha, and there can be bulla in the middle turbinate. So these are the superior turbinate concas, which are again aberrations. Now, this study done by Ingels and Linder et al. Described all the normal abnormalities and deviation from normal anatomy. And from a surgical point of view, it is very important to be aware of the stellar and pneumatization variants also, as all we are very aware. The most common sphenoid stellar, which is where the surgery is easier, and the most difficult cases to operate are patients with conchal variants. Now, these are again sphenoid septal variations. Now, from surgical point of view, the appreciation of the middle septum of the sphenoid sinus can provide a basic idea about the midline. However, it is important to be aware of these variants in deciding where the midline rises. Now, these are again the normal anatomy, where you can see the sphenoid ostium deflecting the middle turbinate. This is the endonasal view of a case of cadaveric dissection. This is the view which we can appreciate. Now, this is our area of interest. The sphenoid area just superior to the sella. And however, it is important, as you can see, all the structures shown in this diagram should be appreciated. These are again the anatomy view of the plenum sphenoidally in a case of cadaveric dissection. Now, this series is a very small series of some 6 cases operated over a period of 3 years. While I was in UCMS, our endoscopic the advanced endoscopic instruments were procured only after I joined. So there are 6 cases which were operated over the past 3 years. Of course, last year there was a lot of clinical profiles hampered by the COVID pandemic. However, still 5 cases out of the 6 were tuberculous meningioma, and the lone case was plenum sphenoidally. The mean age of the patient was 42 years. Now, this is the pre and post-op MRI of a case of plenum sphenoidally, meningioma, which was successfully excised. As you can see in the post-op MRI, there is no residual tumor seen. This is another case of tuberculous meningioma. The topmost figures are the pre-op, and as you can appreciate in the post-op images, hardly any tumor is seen. Now, this is the operative video. of the case of planum fibulae. As you can see, we are just going ahead initial stages to raise the Hadar flap, which is a very important step, which can help us in reconstruction after the tumor is excised. I'll be going fast due to constraint of time. So as you can see, we are just dissecting the Hadar flap, deflecting it from the nasal septum. Now, once the Hadar flap is raised, the middle turbinate, as you can see, is easily appreciated, and we are straight away going into the bony dissection. A bony dissection is being carried out here. Tumor is being now the drilling is started just to enter the sphenoid sinus. As you can see, the drilling is going on. After the drilling of this is the final step, final stages of drilling. And as you can see, the dura is gradually coming into visualization here. There's a small risk of bleeding from the cavernous sinus, just controlled with flow seal. As you can see, the final chips of bone are being removed. Now, this is the dura, which is the intercavernous sinus here, as you can see, which has been coagulated before the dura is cut. Now, after the dura is cut, the tumor is gradually coming into visualization. We are going ahead with piecemeal dissection of the tumor. For this case of tumors, it's very important to appreciate that there are critical neurovascular structures lying. So, always the more helpful strategy, which I feel, is to straightway approach the anterior pole and start dissecting from the anterior pole backward, because usually there are no important structures. As you can see, we are straightway going into the anterior pole, debulking and deflecting the tumor. In the plane, fossa is a useful adjunct for these tumors. Now, this optic chiasma, as you can see, while deflecting the tumor from the anterior to posterior, this optic chiasma is gradually coming into view. This is the final piece of tumor which is being removed. This is the optic chiasma. As you can see, the anterocerebral arteries are also gradually coming into visualization. These are the anterior cerebral arteries, and this thing is there. Now, these are the final bits of tumor which are being removed. Taking particular care not to injure the adjacent critical structures. Now, this cavity was filled with flow seal because to assure proper hemostasis. And after the hemostasis, with the help of Hadar flap, this is the final stage where we reconstruct. Now, this is another video of a tuberculum cella meningioma. I'm going fast. I'm skipping the initial steps here because those are already shown in the previous video. So we are just entering the sphenoid here. Drilling is going on. This is the planum sphenoidally where the drilling has been carried out. The bone drilling is going on. A little bit faster. Yeah, so after the bone is drilled out and the bone is very thin, it is very easy to break the thinner remnants of the bone with a dissector. You can break it out. The dura is gradually coming into visualization here. And as you can see, after the coagulation of the dura, once you open, you straight away enter into the tumor. The tumor excision, piecemeal dissection of the tumor is being carried out. After coagulation of the dura. This is the tumor just after the opening of the dura. Popping out from the dural opening. Initial debulking is being carried out. Fossa is always helpful, more so in fibrous tumors. As you can see, this is the anterior communicating artery, which is gradually coming into our view. This is the structure, or this is a schematic diagram showing the relation of the tumor. Now the anterior cerebral arteries are coming into visualization, as you can easily appreciate. Careful dissection and tumor debulking is going we were going ahead with that. And as you can see, the final bits of tumor are being dissected out. This is a reconstruction with a fasciolata. After I usually do double layered closure. Initially, the Hadar flap is placed. After that, TC and with the help of that fasciolata is implanted. Now, overall, 4 cases were gross totally excised, and the other 2 cases only debulking was possible. In one of the cases, there was brisk bleeding, so only debulking was possible. There was significant improvement of visual symptoms in our series. However, unfortunately, there was post-op in 2 cases, and one of them expired due to meningitis. Now, the main challenges in this approach is that it is a very steep learning curve. It is always important to get familiarized with a normal endoscopic approach before trying to do endoscopic extended approaches, and in-depth hands-on training, virtual reality-based simulation training, and specific endoscopic skills are needed to be able to recognize multiple anatomic landmarks, which are very important for safe performance of this surgery. The key considerations of spinal sinus, and it's not the variant of the spinal sinus, particularly in the patient, relative position of the critical structures, mainly optic chiasma and the pituitary stalk with the tumor, lateral extent of the tumor, degree of calcification, because if the tumor is very calcified, it's very hard, so difficult to do debulking. Even CUSA sometimes is not very effective. Of course, involvement of the optic nerve is not a contraindication. Now, most amenable lesions with this approach are lesions which are not exceeding 4 centimeters, mostly midline lesions. Those that maintain and their erectile plane can be appreciated with the help of pre-op MRI. Tumors encasing the neurovascular structures in total are not ideal cases, and those that they have aerated well-read spinal sinus are easier to do. So to conclude, I'd like to say that patient selection is a key in this approach. Overzealous use of endoscopic endovascular surgery for poorly selected patients can lead to devastating results. The learning curve is steep. Post of CSF leak, if it occurs, always pose a big challenge. In fact, initial 2 cases, I had quite a lot of difficulties in managing the post of CSF leak. One of them, as I showed, expired of meningitis. And of course, preserving the critical neurovascular structure adjacent to the tumor is very important and cannot be emphasized for optimum results. Thank you for your patient hearing.
Thank you, Pragyan, for a good technical presentation, a good technical note. Of course, there will be controversies, there will be questions. Anybody from the house would like to raise some questions? Anita, your comments?
Yeah, very nice presentation, Pragyan.
Yeah, thank you.
It's really important to select the cases, which cases are suitable for endoscopic approach, because as you also said that there was 1 death and 2 patients had leak, and 2 patients you could not remove the complete tumor. It's a very good approach, no doubt about it, because you attack the vascularity in the beginning. But I just want to ask, you didn't repair your base with the bone, you just put this Hadad flap. And a dart flap is the final thing, because ultimately it is carrying the nasal flora and all, because nasal bacterial flora and all. So if you are putting under directly the dart flap, that is a source of infection to the brain. So ideally the floor should be covered first with your all flow seal and all kind of sealing agents, then fat, and thereafter bone. It should be repaired in such a manner the way you have removed the structures. And then finally put the Hadad flap and reinforce this whole bony underneath, then with the Hadad flap. So that is how you can prevent, of course. And the second thing is the bony removal is very extensive as compared to the just transsphenoidal approach for the pituitary. The bony excision is very extensive in this area. So the post-operative complications related to the nose, like breathing problems and all, they are more with this kind of surgeries which are involving the removal of the anterior skull base or the extreme part of cribriform side of plate or the planum. So that challenge is always there with the patients.
Yeah, thank you, madam. Madam, actually, I do use fat. The video fat was there because there's constraint of time, so I skipped that step. So regarding the placement of the bone, yeah, this is as I told you, this is a steep learning curve. I'm still learning. So I was not able to, initially I didn't remove the bone piecemeal. I mean, I drilled the bone throughout. So in the initial few cases, it was not possible to put the bone as a supporting structure. But fat, tissile, fossil, and fascial atom was always used. I mean, sorry, Hadar flap was used. And the case which had this meningitis, that time I was the Hadar flap I couldn't raise successfully, to be very honest, because it was very initial stage. And so ultimately, from third case onwards, I did a lot of cadaveric dissection also before going ahead with the approaches. So nowadays I regularly do in my institute on days which I don't have OT. So yeah, those are helpful.
Yeah,
But
it's a long learning curve, no doubt about it. It's a
learning
long
curve is steeper, definitely. I appreciate it. Thank you.
See, there are certain things like trans-sphenoidal approaches for pituitary, well established, well done, and we accept it as it should be done, number one. But I would say that when we come to these kind of tumors like meningiomas, there's no clear-cut great advantage of doing a trans-sphenoidal surgery over a transcranial surgery. So sometimes it is safer, to do a transcranial where you see all the vessels before you come to the tumor, and the chances of damages are much less. So, I mean, that way, from that perspective, unless the tumor is really very small and you can just get away with it, I would still prefer to go ahead for these tumors by transcranial route. Maybe you can call me an old timer, but that's what I would prefer.
Yeah, okay.
Yes, I agree with you because long learning, steep learning, special. Transcranial is also not very bad. Because the cases which we have done, given we are seeing.
Sir, you are not audible, sir.
So, I think the voice has gone.
Exactly, sir. Actually, what we remove the bone here, we remove that much bone from underneath through the nose. So we are creating that hollow cavity inside the nose. We are damaging the turbinates and all. So that breathing problems and all kind of problems, they are always there with these kind of patients when we are going transnasal for this kind of big skull base removal. So that you're right, that that cranial approach is also as minimally invasive as the transnasal approaches for these cases.
Thank you, Pragyan, for a lovely presentation. Yeah, I think we should be able to catch the presidential oration now over there in Hall A after this.
Thank you. Thank you very much.
Thank you.
Yeah, it was a wonderful scientific session, and everyone must have enhanced their knowledge. And thank you, Dua sir, and thank you, other chairpersons, speakers, and delegates. We would conclude this session here. Next session would commence tomorrow, 8 a.m. For split session, that is neurology and neurosurgery, with the award paper session. Thank you, everyone.
Thank you.
Thank you.